medicine is interacting with patients. No one cares how much you know until they know how much you care.
Why the hell do you guys need to work 30-hour shifts? Like, how does that even make sense?
Time is brain. Every minute, millions of neurons die. So you have to do it ASAP.
What about seeing death?
One of the largest causes of deaths is iatrogenic, meaning caused by medical errors. Just think about that. You wake up and you're like, you cut my whole arm open, my fracture's on this arm. Symptoms are related to disease. Dis-ease is disease. Well, I was working around, I would say an average, just ballpark average, about 60 hours a week, which is not bad. It's actually not bad.
You know, you doctors are really funny, right? Like 60 hours in any profession outside of medicine is like, you don't have a life, right? And that's a good week for you guys. And that's crazy.
Someone who's not comfortable being uncomfortable is someone who may not be able to adapt very well in medicine.
The major insecurity for all of these guys was, how do I make money? And for them, it was like medicine. Anyone listening that wants to become a doctor, I really hope you know this. So today with me to discuss another career, I have a Doctor of Osteopathic Medicine and with a specialty in neurology, Dr. Evan Gray. Nice to have you here. How are you doing?
I'm doing great. Thanks so much for having me.
So when you hear about a DO, that's what it stands for. I didn't know. That's why I'm enunciating. Doctor of Osteopathic Medicine. And a lot of the doctors that we probably run into are DOs. I just wasn't familiar. Do you actually have to tell a patient when you see them that, hey, I'm a DO or MD, doesn't matter?
Frankly, I don't even bring it up. Sometimes it will matter based on what I do and talk about with them. And sometimes they'll ask me. I don't really get that often, but typically, no, I just say I'm Dr. Gray.
Oh, okay. Well, very nice to have you. I'd love to just start off as broad as possible.
All right.
What is a doctor of osteopathic medicine?
Okay, so a DO is, and this is something, again, I'll get into, but I didn't know much about it either. In fact, it was totally serendipitous that I became a DO, which is a funny story. But Doctor of Osteopathic Medicine. So I'll just say a DO and an MD are basically two peas in a pod. In a large part, they're equivalent. Now, some MDs might get upset about that. Some DOs might get upset about that because there are important differences. But by and large, a DO can become any kind of doctor, any kind of specialty. They can practice anywhere in the United States or Canada. There's no restrictions. So other than the two letters at the end of the doctor's name, there's literally no difference by and large. But osteopathy focuses on a couple principles that are different, or I should say that we learned in medical school. So the one thing is that there is an interconnectedness between the body, the mind, and the spirit. Now that sounds kind of, Eastern medicine, like, holistic, but it is. It actually is do that. And the founder of osteopathic medicine, Andrew Taylor Still, A.T. Still, he founded the first osteopathic medical school in Kirksville, Missouri, back in the late 1800s. He was an MD himself. During Civil War, around that time, he had 3 children, and they all died, unfortunately, of spinal meningitis. And of course, back then, our medicine was very rudimentary. We didn't have hardly anything. That was before the advent of antibiotics. So really, when you get an illness, oftentimes that's, really, really just hoping for luck at that point. But he became disillusioned and he wanted to do something else because there really wasn't many options. And he actually grew up near a Shawnee Native American settlement. And so there was a lot of, I imagine, a lot of influence from there. But other things too. He was actually seen as sort of a pariah. And when he was doing these manipulations we'll talk about, people called him, possessed by the devil kind of a thing, because it's, when you don't understand something, it's very easy to criticize. But eventually he became using it more and more. And eventually he landed up in Kirksville where he wanted to actually teach it to other people. And he actually had his first graduating class was around 20 people. I think there were about 5 or so females, which was very progressive at the time. So, but going back to your question, the principles in practice are related to mind, body, spirit. It's all interconnected. We are not a bundle of symptoms. We are a human being with the potential for health. We have symptoms. Symptoms are related to disease. Dis-ease is disease. So we're not at ease. There's something off. And as is true on a day-to-day basis that I see, especially when I go looking for it or someone comes with a specific complaint, the musculoskeletal system, which we can get into as well, is a collection bundle of nerves, tissues, muscles, arteries, veins, literally everything that we hold is encompassed within that tissue. And as osteopaths and Dr. Still learned, you can manipulate, you can assess patients, treat patients based on changing the way we fit together. And so it's all about structure and function. Structure is related to function. And so if you have some, you have, to put it simply, you fracture your rib. Okay, well, you're not going to be able to walk very well, or you might not be able to breathe very well because your ribs are on the outside of your rib cage and you have to breathe. There's the intercostal muscles that allow you to inhale, exhale. So that's going to be impaired. And so someone has a rib fracture and develops a pneumonia. Well, there might be a reason for that. You're not able to expunge all the gunk that gets in there. So that's sort of an idea of when I see a patient, when we're trained, when we see patients, is we look at sort of the whole person, right? It sounds cheesy, but it's actually true. And even though some osteopathic medical students, some of my classmates were kind of skeptical, maybe I was too. It's like, I just want to know how to treat a heart attack. Like I really don't care about chest pain that it could be from a rib, but actually you can really, really help patients right then and there in front of you. So that was a long-winded answer, but you can tell that I'm really excited about talking about this.
Yeah, I mean, that's actually exactly what I wanted to get out of that, because I mean, you're a doctor, you treat patients. So where is the disconnect between DOs and MDs? Because I mean, to pardon my ignorance, but I'm a lawyer. I don't know anything about medicine. My concept of a doctor is, hey man, I got a problem, and can you help me out? And so I go to a doctor, and they tend to whatever my problem is. So are you saying the disconnect between, or maybe not even a disconnect, difference of opinion between a DO and MD is that a DO will look at the entire patient from a mind, body, spirit perspective, whereas an MD will look at them from what perspective?
Yeah. So, I mean, nothing against the MD colleagues. I mean, I see them as equivalent. Really, I would say, and again, this is a general principle. This is what we learn in medical school. As we go through our career, we have different approaches. We may be influenced by other physicians, the hospital system we work in, the number of patients we see. It's really, really, it can be very scattered. And so this is sort of for those interested in learning about osteopathy, this is sort of the principles, the ideas of what's behind it. So, I mean, the approach, yeah, like I said, osteopathy, we are taught to look in a more holistic way, not just the back pain, but back pain and, oh, you had a neck injury too, and it started at the neck. So we'll kind of dig more. We won't just look at the back pain, look at the back only, treat with medications, which obviously oftentimes is indicated, but we'll also look at other ways to correct the dysfunction, if you will. And again, this is what we learn, not necessarily done in practice. And there's so many different ways to address this. It might just be you treat the same way as an MD with medications, but you might think differently. And therefore, when the patient comes and talks about their back pain, you might say, you know what, how have you been feeling? Oh man, I mean, they might say, I had back pain and I can't do sports anymore. And that's really impactful, because the back pain is one thing, but how is it affecting your life is the other thing, right? We can say it's 10 out of 10 pain. Here's some medication. Great. But I still have difficulty moving because of the back pain. I'm not in pain anymore, but my back has dysfunction, and therefore that is limiting me. So in my field of neurology, I'm all about symptoms because that's what they come to the doctor, but function, right? There may be a disconnect there. They may come in with a tremor in their hand, but they might say, no, it doesn't really bother me. What really bothers me is this little fingernail right here. I say, oh, okay, I should have asked that at the beginning. But you have to put two and two together. And if I see someone with any degree of symptom who is significantly impaired in whatever way that may be, physically, mentally, emotionally, that's where I go into and try to focus. And so I think being going through osteopathic medical training, I think has helped me look into more than just the chief complaint.
Hmm. So this might be a stupid question, but I might as well ask it. You guys can prescribe medicine as well, right?
Yep, everything like an MD can do, we can do.
Okay, that's good to know. Um,
We're surgeons, we're obstetricians, we're pathologists. Every single medical specialty that's out there, we can do as well.
that is cool to know. I didn't know that. Anyways, we'll learn more. That's the whole purpose of this. How many years of experience do you have as a DO?
Well, kind of depends how you count.
Okay, so when did residency start?
Residency started in 2018.
Okay.
From 2018 to 2022, so that's 4 years in neurology. And then I opted to do an additional year of training in movement disorders, which is a concentration in, among other things, Parkinson's disease, tremor disorders, gait abnormalities, walking abnormalities, that is, dystonia. Anyway, and then I started practicing here in Northern Virginia in a private practice August of last year. So been in private practice for a little over 6 months now. So
Nice. Well, that's cool. So it's about 6, 7 years now, right? So why did you want to become a DO? And did you, in the beginning, want to head into neurology, or is that something that dawned on you during your schooling?
yeah, very good question. I think about this a lot because it's just really funny how things work out. So no, my mother, and my grandfather were both MDs, were both physicians, and MD for me was synonymous with the physician. DOs, I honestly didn't really know about at all. I might have seen it, but never dawned on me what it was. I always thought MDs are the only way to go, and that's okay. And so when I was applying to medical school, I did really well for my GPA and science GPA in undergrad. Like I studied my butt off. I sacrificed a lot of my free time, and I enjoyed it. Of course, I like the challenge, the intellectual challenge. And so I thought, oh, I mean, I'm gonna pass the MCAT in flying colors. I mean, if I did really well on these hard classes, this will be easy. Well, that was wrong. So I ended up taking for all those people out there that are concerned about matriculating and getting into med school, just listen to my story. So I took the MCAT 4 times. That's a lot. And the thing about that is when you take this test, they look for the score, and some schools might take the top score. Some schools might take the average score. Some schools might say, oh, you got a low score despite the high scores, we're going to take you off our list. So that was kind of my anxiety. I was like, I don't actually have a plan B because this is literally the only thing I'm doing. That was kind of my mindset. Ended up working out, but that might not have been smart at the beginning. And so my first year, I took 1 year off between undergrad and medical school. No, sorry, 2 years off. I was going to intend to take 1 year off to study for the MCAT. So I took it, and I took it actually 3 times, and I did not horrible, but definitely not up to speed with what you want to do for medical school. And so I was freaking out. And I said, finally, I'll do a class. I'll just take a class. I'm not as smart as I thought I was. Really, it's just the art of test taking. But anyway, so I did it, and I got better. But still, I was like, well, are they going to average the score? Are they going to look at the low score? I don't know. I mean, I got respectable, nothing like Harvard, nothing like that. And I wasn't really hopeful for that either. But then I started looking into osteopathy, osteopathic schools. And again, I didn't really know much. I was like, well, there's these schools. I heard they have lower, quote unquote, lower standards for admission, and so I'll apply. And I received a call, I think December 18th, 2013. I was working in a medical clinic as in the front desk, and I got a call, and they said, I'm accepted. And I almost thought it was a joke because I didn't even have an interview. And we always do interviews. So I was just like, is this really true? And so I got into Michigan State College of Osteopathic Medicine, and frankly, I did not want to go there because it's an immature answer. But I'm from Michigan, Ann Arbor, Michigan, so I was like, I don't want to be a Spartan. No. I mean, it's kind of like I want to be a doctor. This is my only chance, but I don't want to go there. But long story short, that's just kind of a funny thing. I went there, and so it was serendipity, and I'm so happy I did it. And we can talk about this, but the things I mentioned in the beginning, are just invaluable to me, the way I approach patients. And not that I wouldn't be able to do that as an MD, but I just think getting more tools and training.
So I was looking into this, and the GPA requirements and the MCAT requirements. I know the MCAT requirements are just slightly less. Sorry, the GPA is just slightly less. I believe it was 3.53 or something for DOs and 3.7. So that's pretty close. I get it. You pretty much cannot get many Bs if you have a 3.7. But for the MCAT, I think there was a 7 point difference, and that kind of matters, right? Because it's percentile. And so when I was looking at that, it's still DO is very competitive. It's just not as competitive as MD, right? And it probably makes sense. Like when I was looking, there were less DO schools, and less people know about the occupation of a DO. So I'm guessing as time progresses and there's more awareness and more people enter the field, it'll get more competitive, and then those requirements will probably match that of an MD.
Correct. Yeah. And it's easy to look at the numbers and say, I want to be at the top school. I have a 4.0, so I have to go to Harvard. I have to go to Stanford. It's like, well, great. That's great. But what do you refer to the person who is last place in their graduating class, meaning had the lowest grades or barely passed? He or she still gets a DO or an MD. It really doesn't matter. I mean, I'm not saying you should barely skid by, but you have to ask yourself, of course, shoot for the stars. If you miss, you might hit the moon, always want to try your hardest, of course, give it a good effort and make sure you're doing what you want to do, of course. Once that's all taken care of, you really need to ask yourself, I have a great resume. I have good letters of recommendation. I love what I do, and I have these great volunteering experiences. I have an amazing passion for what I do. I talk about this in my interview, but they turned me down because I had a 10-point lower score compared to my counterpart it's kind of like, well, do you want to go to that school? Do you want to go to the school who may undervalue you or overlook you because you have a slightly lower score? Now, there's kind of a reason for that in a way. Like when I work with my patients, I don't look at numbers and say, "Oh, you're a lab value. You're an MRI finding on your brain MRI." No, you're a person with symptoms and complaints and problems that I want to solve. I'm not going to single you out based on a number. But analogous to that is, oh, you have a 3.5 GPA, but we take 3.6 and above. It's like, if you do a cutoff of that, and this is true, for some schools, they will literally draw a line and say, anyone below this that has a lower score, we're just throwing out. And you have thousands of applicants. You have to make a decision, right? And so it's probably easier doing that than actually going through every single person, interviewing them. There's utility there. It makes sense, but you may be missing a lot of people, right? So we have the street smart, quote unquote, and the book smart, quote unquote, and you have to have a little bit of both as doctors. And so long story short is, yes, you have to be competitive. I mean, you have to get really good grades, and but don't try to focus too much on the nitty-gritty numbers. Know what the average is, just to get a kind of a ballpark, right? Just be aware of that, because you have to know that. You really have to know that.
But I think if you're going into, I kind of disagree, because if you're becoming a DO or MD, you have to be so studious, right? Like, if you're not concerned about the numbers and obsessed with that, good luck having a 3.5 plus GPA. Like, that's not easy, right? What does a 3.5 plus GPA say? It says that, hey, you really prioritize your education during your undergrad. Like, I think that's all it says, right? I don't think you're smarter. I don't think you're dumber.
Yeah.
It just means that the amount of hours that you had, you put more of that towards schooling. Right. And so, because I've met some dumb people I shouldn't say dumb people that lack different types of intelligence, but they're academically stellar. Right. And so they'd have a 3.8, 3.9 because they're exceptional test takers, and they know how to get to the point with respect to whatever they're studying. You see them in real life and you're like, how do you function? Right. And but I do think it's important that if your goal is, if you want to go to med school or DO school, it's not easy getting a 3.5 GPA, especially in your undergrad when you're an immature kid, right? 18-year-old versions of us, right? And 20-something-year-old versions of us are very different creatures,
Right.
right?
Right.
And so I feel like you have to be obsessed with,
Right.
you know,
Oh, I understand. I understand. But just when you're looking at 3.5 versus 3.55, and the average, you look at a website, average GPA for incoming students is 3.55. Oh, I have 3.5. Oh my no. Oh no, no. It's just an average, right? And you should value who you are, who you want to be, your attributes, your resume, your volunteer experiences, your passion, your patient care, all that stuff, more than just boiling down to a number. All of it's very important, right?
I
But
get
the
that.
the goal
Yeah.
is to make sure you want to go somewhere where you're actually wanted. And if you're gonna go to a school that is just gonna cut you off because you're under their quote unquote standard, then maybe that's not the best school to think about, you know?
hmm And that's probably a very normal thing in the medical field because, I mean, I think it's the toughest program to get into, right? Like, just to become a doctor, I think is like the toughest. I don't think there's
I
any.
think, I mean, someone had told me that getting a veterinarian school is harder just because there's less of them.
Oh,
So if you
okay,
look at
okay.
the percent, getting in, maybe that's more. But I mean, yeah, I mean, being a lawyer, it's all
Oh,
hard
no,
on their
no.
own.
There's absolutely no pride associated with this. I could care less. It is not. To become a doctor is way harder than becoming a lawyer. I mean, yeah, that's what I said, right?
Yeah,
It's late, but
to
it-
each
it-
his own. It's a incredible journey. Whatever you do,
I think you guys have to go through, and we'll talk about this.
Yeah.
4, 8, 9, 10. I mean, 11 years almost before
Yeah,
you're like a full
yeah,
fledged
minimum
physician.
11 years to become a physician. Yep,
You're
including undergrad.
you're a lawyer at in America in 7, in Canada in 8, right? So I mean, it's light years apart.
Right.
And our
Well,
schooling is not as hard as yours. Like our schooling is very difficult from a different perspective, right? A lawyer would find it difficult. And by the way, the reason why I can talk about this is because my first degree was in science. And don't get me wrong, nowhere near as difficult as med school. But I've undergone, molecular bio and taken
Yeah.
some of the more science-oriented classes.
Right.
And I mean, those are brutal, right?
They are, they are.
And the amount you have to memorize, the amount of connections you have to make, how you actually have to see.
Right.
Law school is not like that. Law school is, you have to understand a lot of the case law, why it actually applies, and just apply it to situations. And it's difficult. Don't get me wrong. You have to reason a lot.
Right.
Right. Everything is just like, does it make sense what the hell you're saying? Right. That's
Right.
what law school is. And a lot of people, especially in first year, I remember there were so many people that had all these like incredible ideas of connecting these bizarre lawsuits and cases together and their answers. And they were like, no, that's not how this works. Right.
Right.
And so I would say they're difficult for different reasons, but medicine, man, is just, I think you guys have one of the toughest professions.
Well, again, I mean, every person, it's easy to generalize, and you're right. I mean, it's not difficult to be a doctor. It's very competitive to get into. I think just the nature of the field, really, because they want to make sure that you're the real deal, that you work your butt off to take hard classes, to take a really difficult admissions test, which of course other fields like law has too. Limited number of spots. They want to weed out. They want to take out the people who are not going to be competitive, are not going to last in medical school. Why? Well, there's a big financial interest, right?
Yeah.
A story is my medical school, at least when I went in 2014, when I was 24, it had about 300 students per class. So that's about 1,200 kids in the whole med school, which is very large. It's like the size of a small college, essentially, maybe twice the size of, or maybe even more. So we all started with 330 kids. And after the first 8 weeks during summer, when we started before the fall semester, we did anatomy. So we were in the cadaver lab, very interesting, but it was just like drinking out of a fire hydrant. It was just very, very intense. Like the material was not that difficult, but it's just like retaining the information, going over all these different parts. And about 10% of the students failed. And I think 1 or 2 did a remediation and got back in, but 10% just dropped out or decided not to continue on. And that's just sort of an example, because you want to make sure that when you go to medical school, number one, the assumption is you want to be a doctor, right? And we'll talk more about that. It's such a huge investment, not just money. That's a whole nother topic, right? All the loans, but emotional investment, right? Things that you could be doing instead, right? So if you're not certain you want to be a doctor, think 2, 3, 4, 5, a million times, because your friends are going to be on Wall Street making millions. I mean, you hear the stories, and you're still going to be maybe in debt in residency. So you have to go into this because you love what you do, you're interested in what you do, and you want to help patients.
Okay, that's cool. I like that. I will say your friends will not be in Wall Street as millionaires. The highest paid profession, I believe, is medicine. Medicine and yeah.
Maybe looking at averages,
Yeah.
We all hear about the sensational, this guy, chose the right investments, and wow, he's, you hear the stuff on, the front page of the
Those
news.
entrepreneurs.
Exactly. Yeah.
I mean, I don't have any Wall Street friends who are millionaires.
I don't either.
Yeah. Okay. So talking about the path of a DO, I want to spend a lot of time on this.
Sure.
So I'm an 18-year-old kid, right? I want to become a DO. And how do I do it? Like, what are the exact steps? And now that you've been through it, we'll stop at each step to see where you can add some insight to make their life a bit easier. But
sure.
What are the prerequisites to becoming a DO?
Sure. Okay. So, and, I haven't looked recently at the exact prerequisites, but generally you're going to have to do a number of science courses in biology, mostly biology or biological based sciences, such as microbiology, biochemistry, physiology.
And this is during your undergraduate degree.
Right. Yeah. So so in order to be eligible to apply to medical school, you have to have a bachelor's degree. So you have to go to you have to get a 4-year degree from an institution in the United States, or, actually, if you want to go to U.S. med school, you can actually go anywhere in the world, technically. But let's just keep it simple with the United States. And you have to go to a 4-year degree. Now, a caveat is there are some students that I knew in my class that started off in community college and transferred, right? So for those listening, especially if, financially it's difficult, that might be something to consider. But going back to this, so you need a 4-year degree, you need a bachelor's. Doesn't matter if it's a bachelor's of arts, bachelor of science. And what I will say is it actually doesn't matter what your focus or major is. It really doesn't, because either way, to get to be able to apply to med school, you have to do the prerequisites. So what are those? You have to take a number of biological courses. You have to take inorganic and organic chemistry. So that's usually 2 years, your first year and your second year of undergrad, 4 years. And then you have to take physics, which you got to take physics. You got to just get through it. It's a tough one. It's a tough one.
I love physics.
You love physics?
I hated organic and inorganic chemistry.
Right.
Yeah.
And the thing is, again, the way I see this is that we have this curriculum in our undergrad institutions in the United States who have all these really hard sciences, right? A lot of it you're going to see in medical school, right?
Yeah.
But the reality is, on a day-to-day basis, do I utilize organic chemistry, physics in my practice? The answer is no. And let's just say I had to. I would look it up. That's what I would do. I wouldn't have to be like, oh man, what's that equation? And Newton's law. It's like, you don't have to know that. Now, the way I see it is it's a tradition. People are stuck in their ways. It's you're not going to have one medical school saying, we're going to scrap that and you can take whatever you want. That's just not going to happen because they have to be accredited. But it needs a larger change. The reason I say this is because science is really, really important. You have to understand that medicine's about science, but medicine is interacting with patients. No one cares how much you know until they know how much you care, right? So like kind of like you said earlier, right? You could have a guy who's a genius, kind of like ChatGPT. Insert the symptoms, boom, it's I don't know, relapsing remitting multiple sclerosis. Like, whoa, what? That's the answer. You go in the room and you say, plainly, you have relapsing remitting multiple sclerosis. The patient's like, what? And you have to sit there. You have to look at them in the eye. You have to lean forward. You have to be patient. You have to give them time to take that in. And then you have to counsel them, right? and it might not be the right time to counsel them, but that's what you do.
Mhm.
And so you don't learn that by doing science courses. That doesn't teach you that. And
But
so
you have to, right? Like that's just a prerequisite.
oh no. I'm just saying.
Yeah.
It's very important to do science because
So
that's
let me ask you that. Do you think that you could have understood everything in med school without taking organic, inorganic, and all that?
well. I think frankly, like the inorganic and organic, maybe a little bit of it is applicable for biochemistry that you mostly have to take in medical school. And the biology is a lot more. Like I felt like because I took the prerequisites and a little bit additional classes. I was a zoology major, essentially biology at undergrad. That the first few years of medical school, we can get into that was a breeze. I mean, it was like this is easy. I just did this a couple years ago, so that was pretty easy. Yeah.
Okay, that's good. So back to the actual prerequisites. So you got 4 years, and you have to. I'm guessing not all med schools have the same exact requirements. I'm guessing that there's a general amount of courses, like you mentioned, molecular, biochem, organic, inorganic,
Mm-hmm.
and I'm guessing different schools have different requirements. That it's not static, is it?
For the most part, and the best way to do it is obviously looking it up. But also, if you're an undergrad or you want to become a doctor, you can go and ask one of the guidance counselors and say what they usually have. If you want to be pre-med, here are the requirements that you at the very least have to take. Right. Some medical schools might require additional things. For example, my medical school didn't require genetics at the time, and I was like, perfect. I'm applying there because I didn't like genetics, mainly because I did pretty bad, and I
You
was
and me
like,
like the opposite courses.
oh yeah,
I like for background, my parents obviously I'm a brown guy. Brown people all were supposed to be doctors at some point of our lives.
yeah,
Right?
of course, yeah,
And so I started life sciences because I was supposed to be a doctor, and then it turns out I hate it. And so I did all of these courses. I love genetics, I love physics, and seems like we're antonyms.
right,
Yeah.
right. Yeah, I mean, and we are a number of professions too, yeah.
Yeah.
Yeah, so I mean, in general, you have to look, but I wouldn't worry too much about what each individual medical school may require because in general, you do the prerequisites, you're going to be in the right place. As you become in your third year, when you're going to start to apply, you will have those all set or you'll be on track to finish it. And then you can say, oh, I need to take psychology. Let me take psychology. So,
Okay. So on that note, you were mentioning about applying. Don't you have to write your MCAT first?
good question. So, and I haven't looked this up. You might need to now what might happen, and again, this could be faulty information, so I apologize to those listening, but you might be able to apply and you might say, I'm going to take the MCAT later this year. Here's the date. And eventually, before them coming to a decision and or interviewing you, you have to actually have that, right? So you have to have it before they say, welcome to our university.
Yeah. Like no med school, obviously, or DO school will let you in without an MCAT. Like that's a prerequisite. I know that because that's an eligibility requirement.
Right.
Right. And I've heard of thousands of stories. I mean, hundreds, I don't know, thousands, but of people writing the MCAT multiple times. So based on my anecdotal evidence, I would say write your MCAT. Is it your experience that people write their MCAT after their undergrad or during their undergrad in the summers or something?
This is sort of the reason, one of the reasons why I opted to take at least 1 year off at their undergrad because I wanted to just focus on that. Like that was, because I remember taking some of the practice tests. I was like, wow, I thought I was smart. I thought I knew this stuff. But the reality is from MCAT on, standardized tests, certainly you have to know the information, but it's knowing how to take a test.
Yeah.
And so that's really what it is, right? Just kind of figuring out what there's a hook, right? You read something and something that changes like that you really need to pay attention to, and then boom, you can really get to the answer. It's process of elimination, reading between the lines, especially for the reading comprehension part. That part they have in the MCAT.
I heard that's
the
hardest for like people that have been studying science their entire life, because I mean most people that want to get into med school, they're like, biochem,
Right,
all this,
right,
and
right,
then
right.
all of a sudden you have to read this poetry,
Right.
and you're
All,
like,
all the more reason to take non-science classes. You know, if I
yeah,
would have gone back, I would have done. No, I was a zoology major, double major with Latin American studies, and then I did minor in Spanish and neuroscience. So I went to Argentina and I speak Spanish. So I studied abroad there, and but um, but if I would have gone back, I would have done like political science or history, something that I feel like maybe I'd be able to apply or at least use or understand more these days versus oh yeah that one cycle of the bacteria. It's like I that's not relevant at all, right?
mm,
And I'm living a life of science, right?
mhm.
So every day I'm reading something about a patient or about something to learn about a patient or an article, and it's like oh yeah, this makes sense, right? But I didn't need to memorize all those things to be able to process that, you know.
That's really good advice because I got A's in all my poli sci's and religious studies and some of the other softer stuff. But because I was always just thinking I was supposed to be in science, I never even considered any of them. I took them as electives. And you should really try all these random things out and see where you're actually good at, right? And
Absolutely.
so whenever one thing I didn't know when I started my undergrad was that you can start and then jump into a major later, right? And so you can get into social studies or social sciences and then somehow end up with a bachelor of science in bio and neurosci like I did,
Right.
right? And I didn't know that in the beginning. You just think, you go into this major and
Right.
then you're just stuck, and it's not like
Right.
that. You can hop around and figure out what you're good and
Yeah,
bad
that's a
at.
big misconception. Like, oh, I want to be a doctor, I'm gonna do this, or I'm gonna be a lawyer, I'm gonna do this. It's like you can pick what you like, you
Yeah.
know. And one thing, very good advice for really anyone listening to this is do what you want to do. Don't do what other people tell you should do or follow other people's footsteps. Now that might be a natural thing, and like that's how I was, you know. But you'll realize that the more decision making you do for yourself ends up being much better in the end than when you follow other people's ideas.
But that's just in life,
That's true.
right?
Yeah.
That we can apply that in
Right.
every element,
Right.
right?
Yeah.
Do things for the right reasons,
Yeah.
right?
Yeah. Yeah.
And it's kind of a lost art because we all just kind of get into our occupations for the purpose of making money, or there's less and less people that are entering their occupations for the purpose of passion and actually following their interests,
Right.
right? Unless you're an athlete or musician or some of those, entrepreneurial things.
Yeah.
It's most people are getting there for financial stability, and I don't think there's anything wrong with that, by the way.
Right. Right. Right.
Um,
It's kind of how the
uh,
world works.
yeah,
Fortunately and unfortunately, yeah. It's a lot of people have economic hardships, and so they're they're a little bit strained. They're not able to have as much freedom as they otherwise would have.
yeah. Well, I think that's why immigrants go so hard for this, right? So the joke about every brown guy needs to be a doctor
Mhm.
is real because all our parents had the same story. We came from a boat, and we all came with $5 in our hand, and we had to start life. And they did. Maybe I'm just joking about it, but that's how they all started their life.
Right.
It's such a common story. And so the major insecurity for all of these guys was, how do I make money? And for them, it was like medicine. That's
Right.
is the highest amount of money you
Right.
can get.
Right.
And so all brown people were supposed to be doctors. Being a lawyer, failure. But anywho, so let's get back to the prerequisites.
Sure.
So we got our bachelor's degree. We wrote our MCAT, supposedly just one time, and hopefully.
Hopefully. Yeah.
And after that, you apply to DO school. Is DO school medical school? I'm guessing they're different, right?
Yeah. So they go through a different application process. They have a centralized application service. I forgot the acronym, but they're kind of one and the same. Different websites. You have to sign up for a different account when you apply for medical school. So what you do need on top of your prerequisites, your MCAT score, is you need letters of recommendation, which is huge. So you usually have to get at least 2 or maybe 3 letters from. Typically, it's a professor at your undergrad. Or someone respected in the field of medicine, maybe a shadowed physician. That carries a lot of weight, right? Because we look for the opinion of of highly regarded people of you, right? Especially if they write specific things about you, not just like he was a great guy, he was helpful. It's kind of like, no, he was inquisitive. He talked to me about his interest. He seems like a really good person to be a doctor. Like that's really good stuff, right?
Mm.
Additionally, you have to do a personal statement as well, which is sort of like it boils down to like the idea of why you want to become a doctor. You write, it takes a long time. It seems maybe easy, but you have to continue to refine it. And so that's something that probably takes, for me at least several weeks to kind of refine and have edited by family and friends. Actually, my aunt, who's a lawyer, looked at it too, and she just tore it up.
Yeah.
But that's how it is. Yeah, so you have to do that, and then you apply, and how it works is you can apply to. There's no limit. You can apply to any number of medical schools you want. You can apply to all the MD schools, all the DO schools.
But it costs money, right?
Of course, yeah. So it does cost money. I think
Like per application.
yeah.
Yeah. Okay.
Yeah, it might be like you have to pay a certain amount for the first 5, and then each additional one is an extra. I'm not entirely sure. They might be changing it a little bit. And then it's one application, right? So you submit, you upload your personal statement, you upload your letter of recommendation, you have your MCAT score in there, your GPA, your transcript, everything, and then it goes to all the colleges. And then that's when they eventually you'll hear back from them about a decision. You're in, you're not in, and then we're gonna extend an interview to you. So it's a nice system. It's all in one place, and it helps you kind of organize like where you want to apply to.
Okay. And then you get into DO school, right? And so what's the difference? I guess what I found was you guys have to learn something called the osteopathic medical program or manipulation technique, right? Is that the main difference? Because otherwise, MDs and DOs are like, I mean, you never went to MD school, so I guess you wouldn't know, but I'm sure you have MD colleagues. Do you know anyone that's been to both? I don't think people would do that. That's a lot of schooling, right?
No, I don't. No. That would be redundant. That would be there's no practical reason. You would be wasting 4 years of your life if you did that. So
Okay.
OMM or OMT, osteopathic manipulative medicine or osteopathic manipulative therapy. Think of it as a modality that embodies the principles of osteopathy, mind, body, spirit, structures related to function, into manual techniques, right? So let me just give you an example. Someone comes in and they have back pain or chest pain. Okay. Oh, okay. Instead of ordering an EKG and ordering some enzymes to look for any heart disease or sending to the ER because you're worried about, chest pain that's related to a heart attack, which, could be, you want to be alert to that. That's why you have your medical training. Oh, they're touching here. Oh, they actually have a rib that's stuck anteriorly. You can literally palpate that. We learn palpation, meaning just touching and feeling and being able to sense subtle abnormalities in the skin, on the surface, right? In the tissues. We can feel again, this sounds a little radical, but we can actually feel the intestines, not literally like grabbing the intestines as if we're going in surgery, but we can kind of feel the structure underneath. We can feel the motion of the tissue. The body is alive, right? These can be augmented by breathing, all the stuff, right? So, you have an anterior rib here. There's multiple different techniques we learn to be able to put the rib back in place. So what do? What's the rib attached to? The sternum and the vertebral body in the back. Okay, so a couple of things I would do. First thing I would do is, let's see what else is going on. Is it just a rib? Okay, let's go to the back. I scan the back with my fingers, and I can tell just by doing this, like, here's the vertebral body. I'm in the back. I'm going down each side, and I can literally feel just by doing this, through training. Oh, a little bit of a divot here. Oh, sticking out here, and I can figure out which way it's rotated, have them flex extend. Then I can diagnose this segment has a flex side bending rotated to the right at T5, the fifth thoracic vertebrae, right? And I can say, okay, I'm going to treat that. You can treat it immediately. We learn different modalities through different positioning, breathing. Takes 30 seconds or less, and then that might correct the rib because it's all connected. If not, you can do more techniques. So that's a structural approach, right? When someone's sick, let's say they have a congestion from a cold, coughing, etc. What is a way that our body rids our system of viruses, or bacteria? What happens is you have a hyper response to the bacteria or the pathogen. Think of COVID. COVID was horrible. A lot of patients had COVID. A lot of patients, unfortunately, passed away from COVID. What was the main insult? So the COVID set it off, but the body went haywire. And so patients developed a unfortunate, very, very challenging condition called ARDS. Okay. ARDS is a condition where your body just goes haywire, your lungs fill up with fluid, and sometimes they use steroids, which is the anti-inflammatory, to reduce that response. So,
What's ARDS?
acute respiratory distress syndrome, I think. Basically, it's just you have some insult to the lungs, and then all of a sudden, boom, you just have this reactive body response to it. The immune system goes into attacks, but it kind of goes a little over more than it should. And then you have these detrimental responses. So imagine a scenario where you have congestion, you're coughing. Okay, so what's going on? Well, you have some sort of pathogen, a virus, a bacteria, etc. And then you have this body response. And this is a normal response. But sometimes, again, it can kind of become imbalanced. So what happens then? So we have the lymphatic system. Lymphatic system is the other way. It's the conduit in which our body, the white blood cells, the infection fighting cells go through, and they go to the tissues, they pick it up, they go back, and they recycle through the blood, right? It's kind of this, everything's connected, right? That's the other thing. Osteopathy, everything is connected, right? So what do? Well, we learn that we can augment the lymphatic system. The lymphatic system will drain into two areas right here called the venous angles. And we can actually loosen up the tissues, and that actually improves the flow. So therefore, there's evidence that by doing these techniques, you can actually speed up the recovery and or the symptoms, right? They might be able to breathe better, right? So these are two examples of many possible examples and conditions you can treat with osteopathy. And this can augment what you're doing. You're giving antibiotics, you're giving shots, or what have you. Augment it, right? So it's the additional added thing you can do on top of the traditional medical training we also can in osteopathy.
Okay, so let me take you to the first example. We had a bad rib, right? How do you confirm that everything is good? And like, are DOs more laid back in the sense, not laid back, I guess. Would you write off the need to go to EKGs and all these other things? Because, I mean, how can you be certain that through the manual therapy and the structural whatever you implanted or did actually got rid of the issue? I mean, you're gonna go on a patient's word. I'm pretty confident if we were in the totality of circumstances, patients are not always the best at telling you whether a symptom has disappeared or not, right? So, like, take me through my thought process.
This is where the art of medicine comes in, right? So let's say a patient comes in and they say, "I have chest pain." Okay, so first off, who's the patient? Let's just say it's a 56-year-old male who's a smoker, who has diabetes, who had a heart attack, who has a weakness from a prior stroke. Okay, so they have risk factors that put them at risk for vascular disease of the blood vessels, right? So a heart attack is up here, right? I mean, I don't care if he says it's up there, right? This guy is someone who's a higher risk, right? So already my suspicion for something, if he says chest pain, is up here versus someone that walks in who's 20 years old, way down here, right? So you have to understand that. That's where medicine kind of teaches you how to differentiate, how to triage who's can be really sick and who's complaining a lot about something, but really, okay, it's really not that big of a deal from a clinician standpoint as far as urgency for medical treatment, right? But if someone comes into me and they say it hurts right here, and I ask them more things about, well, how does it hurt? You kind of ask open-ended questions. They tell you about it. Okay. You kind of have to extract information from them without putting words in their mouth. Okay. And then with osteopathy, you can touch the tissues. You can figure it out. Structural musculoskeletal pain is different from pain from a nerve, pain from a cardiac issue, pain from constipation. It's different. Okay. It's very different. And so, especially if when you diagnose it and treat it and it gets better, there you go. Now, for their own experiences, their comfort level, or for medical legal issues, doctors may order extra tests. There's nothing wrong with that sometimes, but I'm someone who, if we have an answer and or a treatment and I fix it, there's really no reason to order more tests. Why? We get what's called incidentalomas. Oh, we got a chest x-ray because you had a cough from allergies. You know, that was diagnosis, but the patient wanted to get, okay. Oh, there's an incidental finding of a little spot. Now what do? the patient, I might say it's fine. The patient, I have something going on. So therefore, you insert another pathology. The patient is worried about this finding, and so, and that's again, this is the art of medicine, right? So I'm less is more. If I don't need to prescribe medication, I won't. If I will, I do. If I don't need to order tests, I won't. Because everything as a neurologist especially comes from the physical exam. Tests are very important. That helps us diagnose things. But they say about 80 to 90% of everything you do to diagnose and help a patient is obtained from the history, from talking to the patient and observing what they're doing and interacting with them.
Fair enough. Fair enough. Okay, I was just going down, my thought. I was playing those examples out in my head, and I was like, we have some loose ends to tie up, right?
No, absolutely.
But that was just an
example. Very good question. Yeah, yeah. And of course, lack of time is, if you have 5 minutes, especially in ER, you're gonna order an EKG. I mean, they're coming to the ER. You don't want to miss that, right? So.
Okay. All right. So we got our bachelor's degree, MCAT, got into school. Is the length of MD school and DO school the same?
Yep, identical. 4 years.
4 years. And I was reading that you need to, in addition to everything that you learn about this, like similar curriculum to an MD, you also have to spend 300 to 500 years with the osteopathic manipulation technique.
Right.
And is that part of the curriculum of the 4 years, or is that something in addition to?
Yeah. So 300, 500 hours, it's interspersed, right? So every med school has differently, I'm sure. But for us, it was sort of just a class along with everything else. Went to physiology, then the cardiac system, then microbiology, and then we have an hour doing OMM, right? So we would start off very simple, and then kind of go through different systems, just like we would for the other scientific classes. So it's kind of scattered in there. So it doesn't seem like a lot, right? You're just doing it in addition to. It's kind of just part of the whole system.
Okay, so you finish med school, and then you're a doctor?
Yes. As soon as you graduate, you have an MD or a DO. That's correct. But you know nothing.
Okay. But
you know nothing, and you can't legally practice.
Don't you have to write licensing exams of some sort?
Yes. So the licensing exam for the MD, it's USMLE. For the DOs, it's COMLEX. Okay. So what they did recently, I think as of 2020, all of the residencies for any specialty, whether it be neurosurgery, dermatology, radiology, neurology, family medicine, pathology, they and there may be exceptions, but in general, when they interview candidates for the residencies, DO, MD, etc., or foreign medical graduates, they have to have taken a licensing exams. There's 3 steps: step 1, step 2, step 3. Step 1 of either the COMLEX if you're a DO or USMLE if you're an MD, you take at the end of the 2nd year. Okay. And this is going to be more of a basic science, right? This is going to be more of microbiology, biochemistry, applied to certain patient scenarios, but it's going to be more heavy in the scientific realm. Step 2 is more clinical, right? It's kind of taking those principles and adding it into patient comes in with weakness on the right side. They have this in their MRI, looks like a stroke, and they might ask questions, right? So it's kind of like clinically, what do you do? Because you're learning more about that in the clerkship, the practical part of the latter 2 years of medical school when you're actually in the hospital, in the clinic, not in the classroom as much, right? That's where you get hands-on experience. So that's step 2. So you have to do step 1, step 2 before actually applying to residency. Step 3 is done during the first year of residency. Your first year residency is commonly called the internship. Basically, it's the first year of any training program you're in. During your internship year is when you take level 3 or step 3, right, of the COMLEX USMLE. And that's much more clinical, right? And it's a lot easier, and the scores don't really matter that much. The scores matter a lot for step 2 or level 2. Step 1, I'm not sure about COMLEX, but I think step 1 is now pass fail.
Oh,
okay. And that has implications. But regardless, step 2 is very complex. Step 3 is sort of like you have to do it because you have to do it. I haven't heard of anyone failing it. If you do, you can take it again. But when you finish your first year of residency, then you have a license. Then you can practice. However, not independently. You're able to practice under a license of a hospital system or something like that. You can't do it legally by yourself.
Okay, so we have to go back. So you got into med school. And so you talked about clinicals, and so what's a clinical? I was reading on this. It was like preclinical and clinical. What
Sure.
is this?
So preclinical is all the book work, let's say. So you basically learn, looking at getting lectures, learning the basic sciences, learning the different systems, cardiovascular, dermatology, gastroenterology, all that stuff, right?
So you haven't chosen your specialty at this point, have you?
No,
So
you
you're a
haven't. You haven't.
generalist in the first 2 years.
Right.
When do you choose your specialty?
So, a lot of people might come and say, I want to be orthopedic surgeon. So, and they might have that preconception, which is fine. And you can change. So a lot of med schools will have like clubs, like, osteopathic or bone club or some funny name like that. And so then what you can do in med school is oftentimes you can, and it varies, right? But you can shout out an orthopedic surgeon. You can have them come for lunch. This is just an idea of some ways that med students can get interested and more experience in certain fields they're interested in. But in general, everyone does the same thing during the 4 years. First 2 years, you're in the classroom, quote unquote classroom. The second 2 years is when, it depends by school, but you have core clinical rotations, meaning, let's say you do internal medicine. Internal medicine, let's say you have inpatients. So you go to a hospital that you're assigned to, you follow the residents and the attending physicians, the head physicians around, and you see patients. You do really whatever they ask you, and you might have specific requirements. And you go to another one, you go to cardiology, and then so there's core rotations. At the end, oftentimes you'll have electives. So you might be able to do, I wanted to do ENT. I want to learn more about the ear, nose, throat, and you might do it because you're just interested, or you might do it because no, I actually want to get more experience because this is what I want to do. You'll be able to start applying for residency during your 4th year. So by the time you're in your 3rd year, you should have kind of an idea of kind of what you want to do. You may not. And my story was a little peculiar because I wanted to do primary care from the start. My mom did primary care. I want to do primary care. I love prevention, holistic medicine. I fell in love with neurology. Totally fell in love with it. And that was the first rotation of my 4th year. So then I had all my application, all my personal statements, all my recommendation. And I was like, oh man, I got to do this over. So not everything over, but I had to do a lot of things over, but I knew it was in the right field. So then I applied. I think you apply in the fall, September, I think the application opens. And then you find out about residency acceptance during what's called the match. And the match is in, you submit applications for residency, and then you get matched or linked to a residency. They rank you. They say, Evan Gray, we're going to rank number 1, for example. And I say, I want to rank them number 50 if I apply to 50 programs. And so if I get my number 1, then I'm going to go to that residency. The program that I ranked number 1 is not going to get me because I didn't rank them. So it has to be a match. It's called a match, right? And so there's a process in which you match, and it's confidential. You don't know. And this happens after the actual interviews, and you interview them, etc. But that's when you actually know, in the latter part of your 4th year, when you still have rotations, that, I'm going to be a neurologist. And then after that, it's sort of smooth sailing. It's like you don't really take it as seriously. You're going to graduate. Make sure you graduate. Don't skip things. Still be professional, but you got in. And so it's mainly just elective rotations from there on out. You did everything. You checked all the boxes. You just got to finish medical school.
Okay. So pretty much 2 years of didactic work.
Mm-hmm.
And then after that, you go shadow doctors, I guess.
Shadow, but then they actually do something. It's like first rotation of surgery, which I would rather work at a desk the rest of my life than be a surgeon. Just because me personally, it's embarrassing, but I never learned how to tie a suture. Not because I just can't understand or learn it, because I was just stubborn and I just didn't like doing it. So I was afraid, right? I was in the OR, and the surgeon said, "Can you close?" Meaning, did the incision, go ahead and close, meaning suture it up, sew it up. And I said, I don't know how to do sutures. Yeah. I said, you don't? Well, come on, I'll teach you. And he taught me, he attempted to teach me, and I tried, and he said, get out of the way, I'll do it. I said, thank God. I was just like under the spotlight, the OR lamps here.
Yeah.
And I'm like, oh God, I just need to get out of here, right?
Yeah.
As long as I just passed, he wrote me a nice review. That's all I need, right? And everyone say, what do you want to do for your career, for residency? I said, I'm not really sure yet. but deep down inside I was like, not this, not this. But you show up, you put a good attitude, you have enthusiasm, right?
But that's a good way to figure out various fields within medicine, right?
Right.
So that's pretty cool. And I find healthcare does that. I learned that in nursing, they have that as well. Other fields don't have that. For instance, in law, I don't know how you can get exposed to 20 different areas of law and be like, there's so many different areas of law.
Well, what about like
right?
in law school? You learn about different stuff there,
They
right?
learn about it,
Yeah.
but what's theory and practice? They're like light years apart,
Yeah,
right?
true,
And
true.
so, I mean, all the theories and whatever I learned in law school, you don't apply a lot of it until a much higher level,
Yeah.
right?
Yeah.
So in your junior years, you don't even get to really enjoy the benefit of the things that you learn, right? Because you get into this chaotic environment and you're like, oh my God, what do I do? And, just like you were with the sutures,
Right.
right? I mean, for lawyers, it's like going to like a mini motion or something like a motion is basically whenever you start a lawsuit, if you want to move the court to do something, right? If you want them anything within the lawsuit, you have to bring a motion. Then you have to go before a court and you have to say, hey, I want you to do this. And that becomes very uneventful after you practice a little bit. But in the beginning, you're like, oh my God. Right? You're like sweating. I remember my first motion ever. I was drenched in sweat and I thought like it was really, really hot in the room. And I'm looking around and I'm the only one sweating, right? And it was a really
A
funny
lot of those in
experience.
medicine, definitely. It's just part of the experience,
Yeah.
It's fun. It's fun.
So back to all right. So we did the 2 years. You write your step 1. After that, you do your clinicals. You choose what specialty to go into. Do you write your step 2 before residency?
Yes, it's a prerequisite to apply to residency.
Okay. Then you apply to your residency program. Then you're already a doctor when you get the doctor credentials
Right.
when you graduate from
Right.
DO or MD school.
Right, but you know
Right?
nothing,
But yeah. And
and you continue to realize you know nothing.
yeah.
The more you know, the less you know.
Yeah. I've heard that from anyone that has some experience says the same thing. And then you get into your residency program. Is it the same length of residency? Residency is essentially practicing under the supervision of another more experienced doctor for a particular period of time. How long is that? And does that change based on specialties?
Yeah, so minimum is 3 years, meaning so the quote unquote shortest residencies, it's not really short, it's still a residency, very grueling. But if you want to be primary care, meaning pediatrics, internal medicine, family medicine, and there's probably a few other ones out there, that is 3 years, right? After 3 years, if you don't further specialize or do a fellowship, then you can start practicing, right? Neurology is 4 years, psychiatry is 4 years, radiology I believe is 5 years, neurosurgery is 7 years, orthopedic surgery I believe is 5 years, urology I believe is 5, maybe 6 years, OBGYN's 4 years I believe. So it really varies.
Okay, hold on a second. Did you say 7 years?
7 years, yeah.
Okay, so hold on. That's 8 plus 7. That's 15 years.
Yep.
Okay, you must be getting paid, right? And I'm guessing between year 1 and 7, you get relevant, consequential increases in. I mean, how can you survive?
Right. Well, let's just say that if you boil it down per hour, you're working for pennies on the dollar. So.
Let's not do per hour because doctors work silly hours.
No, exactly.
Right?
What I'm saying is that they have what's called duty hour rules, which is basically most recent I checked is they have the ACGME, which is the governing body for graduate medical education, aka residency, postgraduate training, and you have to do by law or by the guidelines, you have to do an average of 80 hours or less per week over a 4-week period. So if I work, let's just say 120 hours, right? Week 1. Then at some point, if I'm working 80 hours the other 2 weeks, the last week I got to work, what it would be, 40 hours, right? So it's got to average out to 80 hours. Now, unfortunately, and I can't speak for me, it was not like this, right? So more surgical specialties, right? So they might have very long cases and they have to learn, right? They have to understand and learn that stuff, or they might do a lot of rounding, seeing patients. They might come at 4 a.m. in the morning. This is more extreme, but these are some surgical residencies. This is what they do, to round, and then they might finish really late at night. And so it's grueling. It's a very, very hard life.
It sounds awful. Uh, uh,
This is why you need to make sure you want to do this field. You have to make sure. You can go back, but that's a long road. Having done medical school and saying, I don't want to do it. I mean, there are people that do that,
yeah.
but that's few and far between. And you got to make sure that even if you're going to stick it out, to please want to do it. That's why when you're an undergrad, you need to get as much experience as possible, ask as many questions as possible, shadow someone, talk to someone, ask all the questions. When you're in med school, if you're not sure what to do, make sure you get as much exposure as possible, because you want to make sure by the time you do residency, you want to do medicine. Now, if you want to switch residencies, you can do that. You have to reapply typically, but long story short, you're in for the long haul, right? And we can talk later about what you can do after residency and practice, but during residency, it's tough. Now, in general, certain residencies might be different, but in general, the residencies that have a little bit more of a relaxed schedule, meaning lighter schedule, they don't work as long hours, right? And this is generalization. Things like physical medicine rehabilitation, physiatry, psychiatry.
What's not long? 75?
So during certain periods, especially early on in the residency, they might want you to have more exposure to, higher level cases. Like, I should say more, be more busy, be in the hospital, right? Being in the hospital, you're more busy. There's a higher patient load. Then you might be more outpatient, not be on call on the weekend. Being on call means having to go into the hospital or answering the phone about certain cases. Like for neurology, we had a lot of strokes, right? So strokes come in anytime. They don't abide by hours. People can have strokes when they wake up, right? So we had to be there at night, So I did about, and it depends on the residency, right? Depends on how many patients you have. Depends on how big the hospital is. It's not, you can't generalize it, but I think I was on call about, maybe 10 weekends a year, or at least one day out of the weekend I was on call. And sometimes we'd have a whole week on call, like 5 or 6 days on call. But you wouldn't do during the day. So you'd be off during the day on call. But that was the exception, not the rule. But as it's honestly, even though it's grueling and tough, it's what makes you a good physician, because you are thrown in the fire. I had a case where I was seeing a stroke, right? So a stroke, someone comes in, they have right side of weakness. Oh, it's a stroke. What do you do? Well, you got to be sure it's a stroke. It might be something else. You got to do a quick examination. You got to get them to do a CAT scan to make sure there's no bleeding, there's no big stroke. You have to, then you figure out, does this need to go to neurosurgery? Does this need to have their clot taken out of their artery? What are you going to do? This time is brain. Every minute, millions of neurons die. So you have to do it ASAP. Well, I had one case when I had 3 strokes at a time. And so I would never be able to do that at any capacity unless I got that hard training, right? And so, that's where you have to figure out who's the sickest. What do I do? You have to be a leader. You have to figure out, nurse, can you help me with this? Talk to the ER doctor. Can you please give me this medication? I need this. And so you have to be the one to stand tall and to take the challenge straight to the face and say, I'm going to do this. And by doing that experience, that seems impossible. And even at the time, it might seem impossible. You get so much better. So by the time I was getting ready to graduate from residency, I was like, oh, a code stroke? All right, yeah, I'll be down there. And I walked in. Oh, what's going on? So I already rehearsed it so many times. And so if I needed help, be sure to ask for help. Don't do everything yourself. That's why you're in a team environment, other physicians and doctors. And trust me, when I was on call early on, when I was doing my internal medicine rotation, because we have to do that for neurology in the beginning, the patient had a fever. I came in, I'm like, oh God, what do I do with this patient? And the nurse said, you might consider Tylenol. Oh, thank you so much. She's like, the simplest thing you just don't think about. But the nurses are there. They help you. They're your friends. And so it's all about communication. That's probably the biggest attribute of me and physician, making sure you communicate to the patient, making sure messages aren't dropped, that there's all that stuff is so vital to making sure
It's
that
funny
there's.
you say that. This happens in every field. I was just working on a contract, and everyone was so confused about how to address this thing, and it was the simplest remedy, and it just didn't come out until like quite some time of brainstorming, and we felt quite stupid. not stupid. It was just like, this is probably the best
Yeah.
way to go. And
Right,
it was
right,
kind of
right,
like a
right, right, right.
Tylenol-like remedy.
Right. I mean,
But
the one of the largest causes of deaths is iatrogenic, meaning caused by medical error. So that's huge. And communication is that's why they have checklists in the OR to make sure, is this the right side? Is it the right arm we're operating on or the left arm? And that's happened before. And then it's like, just think about that. You wake up and you're like, you cut my whole arm open. My fracture's on this arm. I mean, just imagine the consequences. So things like that. I mean, people who are very quote unquote smart and studious and intelligent will overlook those things. But that's human error. That happens.
and they're also tired and
Yes.
normal life stuff happens, and they might be the last patient of the day or
Right.
the
That's
or
why
the first.
duty hours are important.
Yeah.
Yeah.
All right. So let's get back to residency. You shocked me with the 7-year, man. So how many years was neurology?
So 4 years, and then I did one extra year in movement disorders. So 5 total years of training.
and is the compensation the same year 1 and 5?
Oh yeah, I didn't. So it depends on the state, right? I was in California, and I was making, and this is back 2018 to 2022. I was making ballpark $60-ish thousand for the first year, and when it got to the 4th year, I was probably making close to 70. And you're working like, well, I was working around, I would say an average, just ballpark average, about 60 hours a week, which is not bad. It's actually not bad. There'd be a little bit more, a little less. But as I got later on, it would be more like 40, 45 hours a week. So it's actually not bad, But
So-
yeah, that's how much you make. And some programs make more. It's usually around that or more that you make.
You doctors are really funny, right? Like 60 hours in any profession outside of medicine is like you don't have a life, right? And that's a good week for you guys. And that's crazy. So
Right.
anyone listening that wants to become a doctor, I really hope you know this. Every doctor I've seen works like psycho, right? So, I mean, I totally like, I
Right.
remember when my best friend was going through his residency, and he was a different human, like altogether.
Yep.
It was just like the hours are crazy. You're not
Right.
as competent as you are, obviously, at the end of
Right.
your residency. And so it's like he's one of the most joyful humans I know. And he didn't look like that during those years,
Yep.
especially year
Yep.
1.
Yep.
And
There's been a lot of focus on work-life balance is big, mental health, not trying to stigmatize.
you guys don't have work-life balance. Like that's a question that I can't even ask you. When somebody, like, if you're dedicating that many hours to work, like, okay, so what's a normal work week for you?
Currently?
Yeah.
Oh, well, currently I have quite a bit of work-life balance. I get up around 6:30, get my son ready, take him to school, drop him off. I show up at the office around 8:30, first patient's around that time. Have lunch around 12:30. I don't really take much longer lunch because I don't want to get too sleepy after food. And I'm already on a roll. And then I get out around, last patient around 4:30. I finish my notes, get out around 5:30, get home around 6, and then I'm with my family. So
That's pretty good, actually.
Yeah, so
that's
I'm
only
more-
an hour and a half more than regular 9 to
yeah,
5, right?
and again, this is highly variable. What setting you work in, what specialty. So, this, yeah. So it really, really depends. Yeah.
Okay. Yeah, but I mean, doctors, you guys got to do something.
Yeah.
I talked to him. I was asking him, why the hell do you guys need to work 30-hour shifts? Like, how does that even make sense?
Yeah.
Right?
So
Aren't you
the-
like killing patients by
so-
hour like 13?
Well, certainly that is a big issue, right? Number one is patient health. Number one, number two, number three, patient health, right? Caring for the patient. So there are rules about that. Just like there's duty hour rules, no more than an average of 80 hours per week over a period. There's also hours. My mom, when she was a physician residency in the 1980s, internal medicine, which is you have to know everything, literally everything, heart failure, pneumonia, strokes, like everything, right? And that's more than I would ever care to know for. And she would do 36-hour call, 3 days straight. I mean, that's just not humanly possible. But by the time you're in your
Hold on.
second day,
36 hours straight. Like, how is that possible? Like, I mean, do you come home and then you sleep for like 3 hours and come back for 36?
I don't know. I mean, it probably would feel like that, certainly. I mean, you're just a zombie. Just think about like just even being awake and walking around, let alone
That's a day and a half.
life-saving patient.
That's
It's
a
a day and a
day
half.
and a half.
Yeah.
How, okay. I'm an attorney. I've been working for quite some time. I think the worst day I've had is probably like 16, 17 hours. And like, that's like, I hate anything and everything.
Right.
Right. And I think our jobs are different. Right. I
Right.
have to pay attention to a document, which is very different than when I was talking to my friend, he was saying that, of course, you guys, everything needs a study and it has to be evidence
Yeah.
based. So, as per the study, you know, you were mentioning your mom did 36 hours. They decreased it to 30, I believe. And the reasoning was they found that too many people were, first of all, they only reduced it because too many residents were dying on the way back home. Right. And they
Right.
live, and if you're a
Yeah.
resident,
Being
you
sleep
have to,
deprived is as dangerous as being drunk.
exactly.
Yeah.
And so then they found that doctors can still make solid decisions uh, with the respect to someone's health. And don't quote me, I haven't read this study myself, but you guys can make decisions when it comes to somebody else's life. You can make a decision and be alert for 30 hours at a time. Like how?
Yeah. No, no, yeah, it's hard, right? Because the hospital is trying to make money, right? And residents are great because they're excited to learn and they're really cheap labor, right?
So 1 second, is it only residency that has these psycho hours?
Um, after that, I would think it's even for the most rigorous specialties. Let's just say surgery. Right? Surgery, you gotta unless you do only elective surgery, outpatient surgery, meaning like, oh, I have a elective spine surgery I'm going to do on Monday for this guy with back pain. It's already planned versus, oh, guy coming in with a brain bleed, got to go in, right?
Yeah.
And so doctors they can pick that. They don't have to do that necessarily. It all depends on where you work, what hospital system, what group you work in, how much help you have, if you have residents, for example, right? But, and so after residency, it gets better. I mean, it definitely gets better. I mean, residency is hard on purpose. Now, just for the record, the longest I worked continuously, and it was mainly not because I had to be there, because I had to continue finishing up notes, was about 15 hours. So that was the longest I had to work, right? And so the 36 hour is that doesn't work anymore. It doesn't happen anymore. It just can't by law. Again, they're looking out for residents. So don't be scared about that. And just know it's a finite period. Once you get out of it, it seems like it goes by slow, but it goes by fast. Then you're out of the woods, and then life gets much better. And again, I can talk a lot more about why I'm extremely happy what I'm doing. I would do nothing else in my life than
Let's
this
talk about
field.
it.
Okay.
Yeah.
All right. So,
Why are you so happy doing what you're doing?
all right.
That's the
So
question.
I walk in the room, and it's a patient. I usually don't look at the chart, so I don't know why the patient's there in the first place. Because frankly, the way I see it, I get biased, right? Oh, this patient was referred for vision loss. Oh, okay. So I'm thinking, what could this be? A vision loss, Now, as a trainee, it might be important, right? Because you want to get the story, you want to ask the questions, you want to do the exam, and you want to go to Dr. Jones and say, oh, Dr. Jones, this is the 26-year-old female with a history of high blood pressure who comes in with right eye vision loss that's been going on for 3 days. Associated symptoms are flashing lights, chest tightness, etc. This is kind of the format which we learn in medical school and how to present. I don't need to do that anymore because I'm just doing work for myself, right? So I walk in the room and I see a patient, I say, how's it going? I just have a nice conversation with them, and it's small talk. I like small talk. I like talking, as you guys can tell me right now. And then I just like, how can I help you? And they just start telling me things, right? And it can be very like, I'm in pain, or they might just start blabbing, or it might be somewhere in between, right? By sitting there and listening to the intimate conversation that you're having, they can be spilling their guts. They can be telling you all about their life, right? That's sacred, right? You are privy to their private information. They might be telling you things that they would never tell anyone else, not even their husband or boyfriend or mother or father or son or daughter, right? And you're there and you have that protected relationship with them, right? It's all confidential. You cannot divulge that information, or you should not divulge that to anyone else, right? Other than if it's within, a practice, another colleague, but you cannot divulge that or spread it out. That's obviously nothing we do. We learn in training about that. And then they come in for something, and you have the ability to help them work through their problem, diagnose something, or if not diagnose something, have an idea of what it may be or what it's not, order tests if you need to, counsel them. So by the time they walk out of the room, they have an idea or they know what's going on. or at the very least, you get down in front of them, sit near them, look them in the eye, and they're able to express themselves, right? Because oftentimes that's what they need. They just need to just get a load off their chest, express themselves, right? They come in for let's use chest pain, but really they're having this anxiety, and anxiety is causing hyperventilation, and they have kind of chest tightness. And what happened? Oh, their grandmother just died last week. So that's what they want to talk about. They haven't talked to anyone. They want to talk about that. So that's really what you need to be there for, right? So just a wide range of human emotions, right?
But this sounds like psychiatry almost.
So I wanted to do psychiatry until I realized, well, I won't
No,
put.
that's not psychiatry. That's like psychotherapy. I believe
Yeah.
psychiatry is like the like addressing the mental symptoms via medicine.
In general,
I
yes. I mean, they do learn principles of psychotherapy as well, but generally it's more medication management and stuff like that. But it's funny. I was interested in doing psychiatry because I'm really into mental health. I've had some experiences myself. Because it's kind of like it's like the elephant in the room. It's so pervasive, so disabling, but because you can't measure it, you can't check a reflux, you can't listen to, like you listen to a heart rate. It's a pervasive thing that affects so many millions of people in the world, billions of people in the world. And yet it's people suffer in silence and they don't want to talk about it. But that's why I do psychiatry initially. My mom's like, every patient is psychiatry. You know, they're anxious, they're coming in, they have this and that. And so that's the idea of communication, right? I emphasize the human aspect of it, right? Because the scientific knowledge is you have to have that, right? Neurology, I think I'm a good neurologist because I feel like I think about everything when they come in about and they address weakness. Well, is this from the muscle? Is it from the nerve? Is it from the spinal cord? Is it from the brain? Is it from they have weakness because they feel weak, because they're anxious, because, all these things, right? So you have to look at it in a huge context, and you get to do that with a patient in front of you. And you might be the last resort. They might have tried other, and as a specialist, they're referred to me for something that the primary care doctor or a non-movement disorder specialist neurologist couldn't do, and I'm able to do that for them. And that's so, it's just so warming for me because you make such a big difference in a life, and that's what gives me the motivation to keep going.
That's why you love it.
I love it. I wouldn't trade it for anything in the world.
You're in the right field.
I'm in the right field. Yep, and you can be too.
All right. We were talking a lot about why you love being a doctor, and so I just wanted to quickly recap everything because this is like the biggest chunk of each interview. It's like the actual steps, right? So we get our bachelor's degree. It doesn't really matter where you get your bachelor's degree from. I mean, what you get your bachelor's in, so long as you finish the prerequisites to get into med school.
Correct.
You write your MCAT, you apply to a whole bunch of med schools, undergo interviews. Hopefully you also had your shadowing or, what do you call it? Letters of recommendation,
personal statement. That you have to have, yep.
Yeah. And then you undergo, once you actually get into medical school, you did 2 years of preclinical, write your step 1, then you do your clinicals, write your step 2, apply for residency, suffer for a period of time. And
one could say suffer, yes.
And then following all of that, you are an independent practicing doctor. And you also have to write the step 3. Is step 3 a requirement or something?
Yes, you have to do that before the end of your first year in order to get a license. And then one more thing I forgot to mention, when you complete your residency, you have to pass the board exam in whatever specialty that might be. So in my instance, it was the American Board of Psychiatry and Neurology. They're combined, so we have to know psychiatry, and they have to know some neurology. It's a small portion. And so we had to pass that in order to be board certified. Now that doesn't mean you can't practice neurology, but in order to join certain practices or maybe certain hospitals or groups, they may require you to be board certified.
Okay. And once you get that license, once you're a doctor, a practicing doctor,
sure, yeah.
Is that license state-based, country-based?
Yeah, so if you're a DO or an MD, you can practice anywhere in the United States, but in order to apply, or I should say be eligible to practice in that state, you have to obtain a license. And all that is just a process by filling out paperwork, everything they ask for that you've already done, basically. You just have to kind of pay the fees and jump through the hoops, and then you can obtain your Virginia license, for example.
Okay. And is that the due diligence of, in the application, they probably ask you, did you get any tickets? Are
Have you ever been convicted
bankrupt?
of a felony and,
Oh,
all
okay,
that stuff.
all that
And yeah.
That's why you don't get into any trouble, because the license requirement has all those questions about, are you bankrupt? I don't know if that's a thing.
Are you currently engaged in any lawsuits? Have you ever
Yeah.
been sued before?
Yeah.
Have you ever been disciplined for unprofessional conduct?
Yeah.
All that stuff. And even it's a headache. It's definitely a headache. So definitely not that you can't practice if you have that,
Mhm.
because there are physicians out there that unfortunately have engaged in pretty egregious behavior and yet still do practice after going through disciplinary action. So it's not a deal breaker, but definitely try to be in your best behavior.
Yeah. Yeah. I had a speeding ticket, and it was like 6 years ago, and I still needed to report that. So that was a little annoying for me, because I had to get it from Canada, and I was here, and I was like, really? It was a speeding ticket.
All the bureaucracy is fun. Yeah.
Anyways, that's what the license requirement entails. Okay. So, but the license that you get will always be statewide, right? It's not like you can apply for as many states as you like, but each license is only with respect to practicing in one state.
Correct. Yep.
Okay.
Yep.
And then can you go around the world?
So great question. So DOs currently are able to practice medicine in around 60 countries, 65 countries in the world, including Mexico, Canada, US, of course, most of South America, probably about half of Europe, a few countries in Africa, Russia, Australia, and so it's most major countries you can practice in.
Okay. So I want to, and this just came to me. I wish I asked this earlier, but a lot of people that become DOs also write the USMLE, right? Why do they do that?
Yeah, good question. So it's to increase their competitiveness. So we didn't really touch on this much, but DOs are proportionally growing faster in numbers than MD students, right? It's about 25% of all applicants or all medical students in the US are DOs. It was much lower previously, but it's growing, right? Still a lot less DO schools than MD schools, but it's growing more. So, but yes, there's still a stigma there, right? It's an unfounded stigma. I should say it's not really appropriate in my opinion. Because you complete your medical training, do your medical training, you should have equal access, assuming you're a professional and following the rules and you're studious in your field and you're a hard worker. But a lot of bigger name institutions, Harvard, Stanford, a lot of them will have MDs over DOs. It's not impossible to be a DO, but in general, tradition, a lot of them will have MDs. And so DO schools are more primary care focused, meaning not that we don't learn about other specialties, but primary care, holistic, whole person care, prevention, all that stuff is something that osteopaths proportionally do more than MD.
Now, is this during the first 2 years?
Oh, no, I'm talking about more osteopaths proportionally than MD students opt to do primary care in residency, meaning
Okay.
family medicine, pediatrics, internal medicine, OBGYN. Those are usually the 3 to 4 fields. So anyway, so the reason and I did this too. I actually took the USMLE. The reason is because I wanted to show them on paper that, hey, I can do this too, And so again, increasing my competitiveness, right? So it's, as a physician, you're very competitive. You have to be competitive, right? The system kind of makes it that way, and you are in your nature. And so, yeah, I took the USMLE step 1 and step 2.
Okay. Oh, yeah. Step 1, step 2, those are all. Oh, but I'm guessing the Comlex has the same thing.
Yes,
Step 1, step 2.
they're analogous, synonymous. Yeah, so I took 1 and 2 for both, just to increase, in case there is any. Oh, you're a DO. It's like, oh, well, you took the USMLE. Oh, so just sort of, it made me feel more comfortable. I don't know if it really would have made a difference for me, but if you want to be a neurosurgeon and you want to go to a top rated program, in a big city, Boston, New York, it's like, well, you probably should take a USMLE. It's just on the safe side.
Is there anything different that you have to study?
There's virtually no difference at all.
So
The
you can just write.
the complex, you have to know the osteopathic principles and practices in OMM. You don't need to know that in MD. So it's basically just study for one, study for both.
Okay. So you can write one on Monday and then the other one on Tuesday, technically.
Yes, you could.
Yeah.
And it's just a 1-day exam.
Okay. I'm sure it's a tough, long, grueling exam. Do you find that it's probably doubtful? I don't think MDs would write the complex because, I mean, they're the norm, right?
There's no point. There's no point in that. Yeah.
Yeah. So okay. So the only reason why DOs write the USMLE is to have a more competitive residency application, right?
Correct. Not required, but I think think about it. And again, this is where you ask other candidates. Maybe you meet someone who's in the school already. You ask around. You call the admissions counselor at that school and say, "Hey, what is typically done?" And we usually recommend that you have USMLEs as well as complex. So just kind of ask around. Every school is a little bit different.
Fair enough. And so, do you think that if you're becoming a primary care DO, you just write the complex step 1, step 2, step 3, you're pretty likely to get a residency. But if you're going into I don't know, I don't want to say more complicated, but a higher level specialty, which requires which is more competitive and has more years of residency. I don't even know if that's an influencing factor. I guess just more competitive. So would you say the more competitive the residency program is to get into, the more you should actually write the USMLE? Because at the end of the day, whenever whoever is looking at your application, you've told them that, hey, I can compete because I've done both. Like, is that what you would say?
I would say generally true. Again, it's look at individually and it depends on the specialty. But yeah, I would say you definitely should think about it. Definitely think about taking the USMLE as well.
Okay.
Again, things are changing. So as time goes on, there's going to be more of a general acceptance and toward DOs. Not that there's not an acceptance, but there's definitely is equivalency. Certainly, no one really cares. Like, oh, you're a DO. Like, another doctor's never going to ask me that. No one pays attention to that. Patients rarely do. If they do, it might be a good thing, honestly, for me. And that's where you can kind of talk about DO. Like, what does that mean? What do you bring to the table? So, the only thing that matters is you're a competent person in your field, whether it be an orthopedic surgeon, neurosurgeon, OBGYN, neurologist, primary care doctor. And that's it. That's all that matters. So once you get your foot in the door, you're good to go. Once you get in residency, other than the grueling hours, the rest is smooth sailing.
Okay. So you're a DO now. I don't have any more questions. You're a doctor. Now that you have some experience, in order to become successful, what type of characteristics do you need to just be a doctor in general? Because, I mean, I don't think it's going to change whether you're a DO or an MD, right?
Right.
So what type of characteristics do you need to be a successful doctor?
Right. I think biggest thing is you have to be willing to sacrifice. What do I mean by that? Because this is just necessary, right? You rarely find someone who, I know one person that has a photographic memory, but that hardly ever happens. But basically what I'm trying to say is you have to study a lot of material and you have to prepare for a long, grueling test, and you want to get really high grades. Maybe not perfect, but shoot for perfect grades. And so you need to sacrifice your time, right? You're going to be in the library, you're going to be in your room studying, and your friends might be going out and having a drink or going to some event, and you might not be able to. Now you can. I'm not saying you can't, but you're going to have to do that more often than not. So you have to be willing to sacrifice and dedicate your time. So you have to be a go-getter. You have to be competitive, right? Because with competition means you're going to put the energy and effort into what you're doing, right? And you just have to strive for greatness, frankly. You have to have a lot of conviction. So competitiveness, be willing to sacrifice, conviction, and passion. You really have to have all those.
I would have to say I completely agree, because every single doctor that I've seen along the journey, and it's more than just my best friend, it is tough. And that's why I can clearly say that, it's not that hard in comparison. Any other profession that I've seen, it's nowhere near as hard.
I mean, if you really want to do it, you'll do it. I mean, you'll find some way to do it. It's it's hard when you're in it, but then you realize, wow, this made me so much of a better person as far as competent clinician. I can handle a lot of stress that most other people can't because we have that training, and yeah. So honestly, it's a difficult prospect to look at going into undergrad. Oh, I got to take these classes. I mean, a confession I have is undergraduate education was the hardest part of the whole thing. Getting into med school was really hard just because of all the prerequisites and the MCAT. Once you're in med school, still hard, but you're actually doing things you want to do for the most part. In residency, you're doing things you want to do, but everything else. So undergrad for me was the hardest, I would say.
Okay, that's interesting.
Yes. Yes.
I also didn't like undergrad, but if you go abroad, they don't have in some countries they don't have a concept of undergrad the way they do in Canada and America.
Exactly.
Right? So if you go to UK, and I did law school there, so I used to see the med students there. They just live there, right? So they have 5 years of schooling, right?
It's right out of high school, right?
Right out of high school.
Yeah.
And so they do the pre-meds and all that. They know that. So the way their schooling system is very different, and they have to write something called the A levels. And this is in high school. And depending on how good they perform on these exams at the age of 17, it is already determined that they will end up going into whatever. Because so suppose you get like a 75, you're eligible for, you're not eligible for medicine anymore, right? And so we're talking about our cutoffs. Their cutoffs take place at 17, right? And I guess 18.
Like I know it's like that in Kenya. I was in Kenya on a mission trip years ago, and there was this really, really smart person. She was very well-to-do and very interactive, and she didn't make it. She wanted to be a doctor. She couldn't be a doctor. Like, there was just no choice. And yeah, at age 17, it's like, you are so immature, you don't know anything,
Yeah.
So it's almost like luck.
But it's done. In those countries, it's like, find a new career. That's crazy.
I know.
But all right. So what type of person would hate being a doctor? Because so many people enter this field specifically chasing money, because there is no field that pays as much as medicine. But now that you've been around so many doctors, what type of personality traits don't fit this job?
I would say, anyone who wants to take shortcuts, anyone who is looking for the easy way out, anyone who shies away from challenges, right? So, anyone who doesn't like new experiences, meaning someone who's not comfortable being uncomfortable is someone who may not be able to adapt very well in medicine, because you're thrown into situations all the time when you got to make split-second decisions, or you got to life or death, literally life or death. Like, a patient's having a heart attack in front of you, you got to do something. And no, I can't even tie a suture, right? But I know that, right? And so I'd be happy to say, I don't want to do this, but then I can see 3 strokes at once, and it's fun, right? So someone who doesn't like challenges, kind of likes just kind of not really engaging with other people as much. Those sort of attributes are going to be very difficult for you to be successful in a career like this.
What about seeing death?
True, yeah. So that's complicated, right? Because depending on the field you go into,
if you're going to pediatrics, it's less likely. Hopefully never. But
of course, yeah. No, but that's a reality, right? That's a reality. Is death is a natural process that we all go through, unfortunately. But it's part of life. We can't avoid it. But certainly, those times when patients will pass, unexpectedly, or they're battling a lot of things, and then you have to deal, you have to be involved in that. So yeah, so being squeamish about blood and stuff like that. There's one student I knew who was like that, but she decided to do psychiatry, and that was fine. She doesn't have to worry about that. Just don't do surgery. But just be comfortable. Just be comfortable being uncomfortable, and jump in and be enthusiastic. You have to have enthusiasm. You have to. You have to.
I've seen some boring doctors.
It could be because they're
just dull in life.
Well, the state of this is a whole other podcast for someone else, but more qualified than me. But the state of medicine these days is very complex, and I don't want to get too bogged down in that, because it'll probably take away from the positivity here. But medicine is all really about the patient, but in reality, it's a business, and physicians are oftentimes seemingly lower down on the focus of improving healthcare, and profits are placed higher on a pedestal. So it doesn't have to be like that, and it's changing for the better. But it does kind of make you seem a little sad when you see a doctor who's a little bit disheartened or just doesn't seem very engaged. And I don't know, maybe that doctor just had a bad day. It's hard to say, but yeah, there are some doctors who seem kind of burned out, and burnout is a big topic that's getting more attention as well.
Yeah. It was the same thing when I was talking to the nurse. So I interviewed a nurse and a nurse practitioner, and burnout was a major thing for them as well. Not nurse practitioner. Nurse practitioner is ranked the #1 greatest job in the United States. And
Oh wow.
yeah, nurses are very burnt out.
Mm-hmm.
So doctors as well. The healthcare field in general is just busy.
Right. Yep.
So your specialty is neurology. So let's talk about that. You mentioned a little bit about tremors and strokes and things of that nature. What's a normal day for you like?
Sure. So I'll have about
When you get to the office.
yeah, sure. I'll get to the office. First patient's around 8:30, last patient's around 4. I might have about 4 to 5 new patients a day. A new patient appointment, I get 45 minutes with the patient. Follow-up patients I get between 15 and 30 depending on the nature of the follow-up. And so today, for example, let's say first patient I had, she had migraines, and she had an ear disorder called Meniere's disease. So she dealt with a lot of dizziness, headaches, nausea, and migraines are something we see as one of the most common conditions in neurology. It's 1 billion people in the world have migraines. It's one of the top leading causes of disability. Even though you can't see it because there's no physical signs of it, oftentimes people
What's
suffer.
a migraine? Like a bad headache?
A migraine is not always headaches. Typically headaches, severe headache, nausea, or vomiting, photophobia, phonophobia. Photophobia is being afraid of light, phonophobia being afraid of sounds, meaning you're sensitive to light, sensitive to sounds. You can have irritability, poor concentration, brain fog, dizziness, just not feeling well, right? They can be masqueraded in many ways. So there's a lot of different ways we can approach those patients through lifestyle, making sure you get enough sleep, looking at your diet, exercise, looking at caffeine intake, alcohol intake, but also we have a lot of medications, a lot of good medications. What else do we see commonly? Sleep disorders, right? So someone has insomnia, or someone has sleepiness during the day, and a lot of that is correctable or addressable based on try to go to bed on time, try to wake up on time. Easier said than done. Even I don't do that, but that's something we could do. But sleep apnea is something we look into. Sleep medicine in general is a subspecialty in neurology. So we evaluate patients who have sleep disorders. Sleep apnea is the most common, but there's other ones too. Narcolepsy, right? People fall asleep at the drop of a hat. That's a pretty severe disorder. Rare.
What?
Yeah. No.
I mean, I'm not familiar with this.
Yeah.
I'm not.
Yeah, narcolepsy is it's a condition where there's a neurotransmitter. It's a chemical in the brain that is low, and the neurotransmitter promotes wakefulness. So it binds to a receptor in our brain, in our hypothalamus, and through many complex neurological pathways, most of which we have no idea, it promotes wakefulness. Patients with narcolepsy can have sleep attacks, which is also called cataplexy, where they will be doing something and all of a sudden they just kind of they get tired and they just fall asleep, right? It could be mid-conversation. It could be...
So these guys can't drive. They can't really... There's many jobs they're not eligible for.
Correct. However, there's really good treatment that essentially can eliminate that. Right. So again, that's where it's difficult, right? Because sometimes patients, I'm tired. I'm tired. Okay. If you don't take a good history, you might not figure out that, oh yeah, my husband, he does kind of fall asleep when he gets excited or when there's a stressful situation. Oh, that all makes sense. Then you put pieces together, and patients will go on for years until being diagnosed with this, and it's just like life-saving. That's what's great about neurology. You look for things that other doctors don't know to look for, or patients don't even bring up. But once you start playing a detective, you can really make a difference. Pain disorders, back pain, radiculopathy, which is nerve root impingement, strokes, patients who've had strokes, either acutely in the hospital or they've had a history of stroke, and they might then develop stiffness in the arm or leg, which is called spasticity, which is the body's response to a weak muscle being overcome by the unaffected strong muscle. So you get a lot of stiffness, and you might not be able to open your hand after a while. And there's treatment with that too, including injections of Botox. Botox is a toxin we inject. People may know about it from cosmetic procedures with wrinkles. Wrinkles are muscle contractions, essentially, and over as we age, that can happen. The skin also kind of loses its flexibility and the collagen in there, especially with sun exposure. So basically, Botox will relax the muscle. It helps for migraines. It's a proven treatment for migraines. It can help with something called spasticity, dystonia, hyperhidrosis, which is excessive sweating, sialorrhea, which is excessive drooling, all these things. And I use it a lot in my practice for tremors as well. Multiple sclerosis, a sad condition, but there's a lot of good treatment out there. They used to think this is how it used to be, right? Neurologists are great at diagnosing, but they can't do anything about it. Well, that's how it used to be. But a lot of these significant chronic illnesses can really be changed regarding the trajectory, because we have a lot of disease modifying therapy that actually alters the way your body responds to it and is affected by it, so to then prevent future disability. And you can create a significant life-changing impact for these patients, and therefore there's just so much satisfaction with this practice.
So we were talking about what you do on a day-to-day. So essentially you get patients in your practice, right? You get somewhere between 8 o'clock and 4 o'clock. And you see a patient if they're a new patient, 45 minutes. If it's a follow-up, 15 minutes. So patient comes in with one of these issues, and essentially, like, take me through that process. Like, what should somebody expect when they actually become a neurologist? Like, I guess common sense would say let's go what I think you do.
Sure.
And then you fill in the gaps for me, all right?
Sure.
So I think a patient comes in, they complain about their problem. You pretty much try to ask them the right questions, and rule out particular things based on whatever your knowledge is.
Mm-hmm.
And you try to narrow and narrow and narrow. And before you know it, you try certain things, and to the extent that it's something that you can try, you try it. And in the event you don't think you can try something, that you request further imaging or some other procedure or some other thing, specialty that maybe I shouldn't have gone down this route. But
I think that was perfectly stated.
Oh,
I mean,
okay.
a summary, right? I mean, it's all, I mean, in general, that's true, right? They come in, let me see if I can give an example. Okay, patient comes in. This is a complex case. Patient comes in. She's 57 or so. I don't remember. It's important as a physician to know kind of their history, right? So if someone's healthy or someone has depression, they have anxiety, they have history of a stroke. It's
But
important.
you said you don't look at the chart.
No, but I asked them. them.
Okay.
And sometimes you don't need to ask. You just know their medications. And it's like, oh, well, you have high blood pressure. You're taking amlodipine, for example, right? And okay, so they come in. So this lady came in. She said she was doing fine and she was swimming about 6 months ago. And then suddenly she felt this pain in her arm and she couldn't really explain it, right? So you ask patients, you can ask, as a med student, you might ask, is it sharp? Is it stabbing? Is it dull? Is it aching? Well, okay, you can ask all that, but just ask patient what it felt like, right?
Mm-hmm.
You know, you don't need to know exactly how it felt like. I mean, it might be helpful in the differential. Is it nerve? Is it muscle? Is it bone, etc.? And she really couldn't explain it. Like, okay, I'm just gonna leave it there. That's fine. And then she said, yeah, and about 2 months later, I started having shaking in my arm. Okay, so all I hear is shaking and pain, and it's on the right arm only. Okay, well, that's all I have right now, right? I'm not gonna pigeonhole myself into this condition. I'm gonna keep my mind open, right? Because I don't want to miss things. I don't want to say, oh, this is a stroke. There you go. Well, that doesn't really make sense because one happened, then another, and it's in the same arm. That really doesn't help. So eventually, I see this lady in front of me, and she has like significant shaking. Like it's almost looks like she's doing it on purpose, but she can't control it. It's not a small tremor. It's pretty big tremor. And this is an otherwise healthy 57-year-old lady. And based on the history, she didn't tell me this initially. When I said initially that it started suddenly when she was swimming, she didn't say that, right? So the med student might miss that, you know? But when you ask, you rephrase the question, you ask a different way. Yeah, I did notice it, when I was swimming. And I didn't necessarily, was it acute onset? She told me that after I rephrased it. So that's the art of medicine, right? Because if it's acute onset, you're thinking, is it a vascular lesion? Is it something like multiple sclerosis? Because that can happen right away. It's not going to be a structural thing. It's not going to be a tumor. That's more of a slow or infection that's slow ongoing, right? So therefore, I'm like, okay, it's this or this. Then I'm figuring out she's probably going to have this finding on my exam. She had increased reflexes, meaning you tap your arm and it goes really, really fast. That means she doesn't have a lot of things and she could have a lot of things. So I'm already narrowing it down, right? So then I do my further exam and I'm like, you know what? She has some features of Parkinson's disease. She doesn't have Parkinson's disease because it doesn't start this fast. But she's got a lot of things going on. This is a really interesting case, right? And as a patient, you don't want to be an interesting case because that means that the doctor's going to be like, whoa, they're going to call their colleagues and say, what's going on with this patient, right? You want to be a boring patient. You want to say, oh, okay, yeah, we'll see you back in a year or whenever you want. This patient, we got an MRI for her brain or spine. I don't know the results yet. But so this patient comes in. She has no idea what's going on. The doctor referred her, didn't know what was going on. That's why she referred to neurology. And we're here and we're going to find out something. We're going to, at the very least, rule out many conditions or rule in something that we can find and then we can treat it, right? And so therefore it's just so powerful what you can do. And that was a more complex example, right? But
I just wanted to kind of know, how does an intake essentially go? Because I'm guessing it's just like patient after patient after patient, and you have to constantly toggle your brain between disorder A, B, C, D, E.
But after I'm only in my first real year of practice, and it's so fun, and I have enthusiasm, and it's just a casual conversation. I don't have to be in that detective mode. It's just kind of like just by looking at the nonverbal cues, right? Nonverbal language is 80% or so of language. It's just looking at them. Kind of seeing what their disposition is, their posture, their facial expressions. That is priceless, right? You can learn a lot from the patient, their emotional state, right? How to approach the patient, right? If there's a language barrier, I speak Spanish. You have to ask differently. You ask the patient, does it hurt? Not really. But you're coming in holding your head like you're gonna faint. Nah. Okay. Well, then you gotta ask it differently, right? So there's just so many ways.
Throw something at them.
Yeah. So yeah, exactly right. So, but you meet one patient with a migraine, for example, you meet one patient with a migraine. It's no patient is alike. Everyone has their own experiences. And that's what I love about it. Because every patient is new. When I walk in the door, it's new. And then a follow-up patient that I see every month, for example, for something, well, they may have new symptoms, or it's nice to see them again. I kind of catch up with them, right? And I can see the progress. Or if they have, something goes bad, that I can kind of look into that more. So it's good feedback for me. It's great forming a good relationship with the patient. And at the end of the day, I feel great. I feel great about myself.
What's the stress level like?
This is biased because I love what I do. And even residency, I said I enjoyed it, which just doesn't make sense. Like, how can you enjoy residency? That's not even a sentence. But no, I enjoyed it. I mean, not saying every moment of it, but I just love what I do.
But you can enjoy something and still be stressed out. Right?
Okay, yeah. So, okay, good point. Let me think about this again. Okay, so stress level, moderately stressful in a way that I had to keep up the pace, right? I can't get behind. I can't dwell too much on a patient I just saw, right? I have to try and finish my note. I don't have to finish my note, but I have to try to, because then it can really pile up. I have to be very efficient in my typing. I can't type every single word that comes out of their mouth. I have to be like, I have to summarize it and put what's important, not what they say. I have to say, they have all these, I'm just going to put this. I'm not going to literally type what they write, what they say, because I'm going to just get lost in the weeds. And then I'm like, oh man, I saw two patients earlier this week. A 31-year-old female who's 11 weeks pregnant, and a 42-year-old female who both have new onset weakness, and they both have multiple sclerosis. And I disclosed that to them. After that, I'm going to the next patient. Maybe I might think about it a little bit, but I have to completely put that away. So compartmentalization is especially of every physician. You cannot get bogged down into the...
And does that stress you out?
No, it does not.
Okay.
But...
Or is that your coping mechanism?
Exactly, yep. So
So
doctors,
it does stress you out.
no, I met a psychiatrist who actually who saw a lot of residents and attending physicians at where I worked, and she was great, right? She was great. Physicians are so good at putting things in there, right? All these things that happen, right?
Well, that's not good, man.
No, it's not. But
That's just internalizing stress.
right, but what are you gonna do, right? As a physician, you see someone with a cardiac arrest who just died. You talk to their family.
Yeah.
Oh, I got another patient coming in the ER. You have to have short-term memory. You cannot remember that right then and there. However, just like when patients come in, all these things are part of our experience. All these things can reveal themselves in different ways. I might start having chronic pain. Why? Well, I never injured myself. I have all this stress going on. I had trauma in the past. All of it's building up, right? And so you get to address that and see that. And this psychiatrist would tell me that physicians are so well at managing these things, but then they start suffering and suffering. And not until it gets really bad does their productivity fall off. And that's when they're in shambles.
So they are stressed.
Absolutely.
Okay.
I love my job. So it's a good stress.
It's hard for you to actually acknowledge that because
No. Stress is normal in life. It just depends on how you cope with it and how you get through it. And luckily, I love my job. And so it makes it much more manageable to manage my stress than otherwise.
But in terms of stress, it's probably on the high end.
Yes. Make sure wherever you work in any environment that you're around people that you like. And of course, most importantly, you're able to do what you want to do. You have flexibility. You have some sort of control or say in what you do. That might not always be possible.
Do you work within a team structure or is it?
Yeah.
I'm guessing it's pretty independent. You just see patients. It's not like a team sees a patient.
Right. So I have my own patients. There's about three other neurologists in my practice. We have a physical medicine rehabilitation specialist or physiatrist who does pain management, injections and whatnot for patients with pain. And then we have about 6 nurse practitioners / physician assistants. So we have a collection of those, and we all work together in helping patients. And so we all see our own patients. But if I see a patient with a ALS, for example, there's a specialist in a practice who does that. So I'll refer them to them because I know a little bit about ALS, but nothing compared to what this other physician does. So therefore, I'm going to say, go to her. She knows more than I do. So we all help each other and vice versa.
So after a while, do you think the job gets redundant? Like I mean, as a specialist, at some point you must start seeing the same exact stuff.
Yes, we all have our likes and dislikes. I'm not really a migraine person, meaning seeing migraine patients, just because the physical exam that's really, really important in neurology is not very important in migraines because usually it's just based on what they say. And so you take a history on the symptom, but you don't actually see increased reflexes, abnormal gait, ataxia, meaning, discoordination, I mean, not that I want to see that, but when I see patients with Parkinson's, I see a lot more abnormalities that I can actually palpably see and address. Migraines are more sort of talking about lifestyle and medication management, which doesn't seem as involved as I want to be. And so therefore I usually say, you should see one of my partners.
But do you feel like the job gets redundant?
I mean, the redundancy I would say would be doing notes. That's one thing that you have to do legally, but also clinically is do notes to document what you do. And so that can be a little bothersome because you're like, I gotta write this note. I want to just talk to the patient and that's it, but you have to actually document what you do. So that can be a little redundant sometimes.
Yeah. But the job itself, you would say no?
For me, no. And granted, I just started. But no, I love what I do.
I mean, you've been doing it it might be the first year, but it's like 4 years of residency and then 1+ year
Right.
of...
I mean, residency was redundant because just the nature of things that we had to do, like we had to do rotations, and that was kind of the similar thing. Yeah, so that's why I chose outpatient because outpatient is a lot more mixed bag. Inpatient, whether you're an inpatient hospitalist, meaning an internal medicine doctor that works just in the hospital, or a neurohospitalist, you see there's a 5 or 6 conditions you see very often. Right? A neurologist, hospitalist might see seizures, altered mental status or confusion, strokes, and that's probably 90% of what you see. For me, every patient of the day could be different.
Mm. So for you, it's not that redundant.
Not for me, no.
All right. So, I mean, this stuff is pretty popular, but how much do DOs and MDs earn differently, or like how much can a DO expect to earn?
So it's about the same, frankly. The average salary, and again, this kind of changes every year because it's complicated. The reimbursements rate changes, government funding for reimbursements for physicians. It's very complicated. But basically, if you are a primary care doctor, internist, family doctor, pediatrician, let's just say on average, and average is an average, doesn't mean it's true for everyone. You're going to make around $250,000, $300,000, which is great, right? Which is great before taxes, right? And so that depends on, do you live in California or do you live in Texas? Texas, no state income tax. California, a lot of state income tax. Do you live in a really big city, New York City? Well, there's going to be a lot of doctors there. So the demand is high, but the supply is very high. If you work in rural medicine, you're going to make a lot more money. You're going to be more valuable, right? If you're a specialist, you're going to usually make more money. There's less neurologists than there are internal medicine doctors, right? And so we're more valuable. Surgeons make the most. They make upwards of $500,000 or more.
Starting off? Well, I mean, they
Yes.
did go through 7 years of
Yeah.
school. So
If you get out, I have a friend who signed a contract, and yeah, he's right. He actually making close to $1 million already, like right out. He's gonna go to Arkansas. So
I mean, 15 years of school.
Yeah.
There better be a good
Yeah.
prize at the end.
yeah.
So okay, so they start off at $1 million. That's crazy.
I mean, that's certainly the exception, but it's out there. The desire for physicians is very high, and they'll pay you well.
All right. So you start off at $200 and whatever $1,000 for a normal family doctor. What does it look like after 5 years, 10 years? Like, what are the raises like for doctors?
So it all depends. There's a few settings. There's private practice, which is you're kind of your own boss. There's group practice, which may be like a company that may own multiple different clinics in an area, a region. And within each clinic, they might have a collection of gastroenterologists and cardiologists, internal medicine doctors, and all that stuff. And so you're part of a larger group, maybe 300 people, including support staff. You still can make your own decisions, but maybe a little less so than if you were in your private practice like me, where I only have a couple other people. So I can literally talk to the boss every day if I want to, or it might be a little bit different. The further you go up the chain, if you're in a large academic setting, academic meaning that there's trainees there, there's residents, but also it could be a nonprofit or a for-profit health system, which is more complicated than we need to go into right now. But basically, the larger the hospital, the more incentive there's going to be to make a lot of money. And therefore, the separation between what you do on a day-to-day basis as a clinician and what the administrations tell you to do is much larger. And there might be incontinuities there and incongruence. So it all depends on the setting and the structure. Look at your contracts, consult Umair Shekhar for that. Yep. And that's what I did too. I hired a lawyer for that. So in that structure, they might have incentives. They might say, if you see this many patients per year, per week, then we're going to give you a 10% bonus, for example, And so, I make 300, now I make 330. That's pretty good, right? And so it might start over and you might have to do that again.
But like based on time, right? Like, let's say within 5 years, like, is there like I know it's such a difficult question to ask because I mean, there's so many factors that you already listed out that make it so variable. So let's just go with the, I guess, family doctor. Like, what I'm trying to figure out is, like if you work in a company, for instance, the raises are typically 2 to 4%, right? Depending on how good you do, and they peg you to a particular scale, and they're all like, somehow you're always, regardless of how good you are, you're always just good, right? So rather than exceptional and based on, so like your raises between 2 and 4%. Is there a similar trend in the medical field, or is it just supply and demand? Do people hop jobs? Like, how does it work in the medical field?
Yeah, no. Oftentimes, physicians who choose their first job will oftentimes change to a different job pretty often, more often than not.
What's often?
Over 50% at least.
No. Like time wise, what's often?
I mean, what? Sorry, what I meant is like most physicians, a good deal of physicians who start a career in the first few years, they might switch to different work setting, a different practice. They might go from private practice to hospital or vice versa. So I'm sure there are some inherent scales or models for them to say the more tenure, the longer you've been here, the more you're going to get. And that's probably true. And same with benefits, right? Benefits is a big thing too, right? You might make $200,000 a year, but the healthcare is amazing. Your premiums are low. They're deducted from your pay. You have 4 weeks of vacation. That's a lot. 4 weeks of vacation is a lot. And so that might be just as valuable to you as, extra $50,000. I mean, to each his own. So the benefits are also very important.
That's true. In Europe, they don't think 4 weeks is a lot. They think that's the standard.
Exactly. Yep,
so my brother-in-law lives there, and he's like, "You North Americans."
I know. No, it should be more like that for sure.
Are there special perks to being a doctor that you wouldn't know unless you actually became one? And if so, what are they?
You get to save patients' lives on planes.
That's not a perk.
No, it's not a perk. Yeah, and you don't have to volunteer for that either. I think I would, honestly. My mom never would. She's like, no. My grandpa always would. He would definitely do that, but he has before when he was alive. But special perks, like there are, yes, for mortgages, you can get physician loans. So what that means is that you actually may qualify for a lower interest rate or not be able to put any money down.
Lawyers get that too. Whoop, whoop.
Nice. Okay. You might get special discounts. Potentially you have a higher, you're just more highly regarded. You're respected more, It's like,
that's for sure.
Dr. Gray, it's like once you get that MD or DO, you're a doctor for the rest of your life. So it's status. You are respected more. You're thought of highly. And so that alone, I think, is a big perk, but, I'm sure there's some out there. I can't really think of anything else, really.
I would say status is definitely one of them. Doctors are seen as, top of the food chain in terms of any profession. At least I would think so. Yeah, they attract a lot of status for sure.
Right. But with great power comes great responsibility. You gotta behave it too. You gotta. Be professional.
It makes sense. Like, you guys save lives, right? I mean, if I make a mistake, some company lost money, and don't get me wrong, that's bad, but nobody died, right?
Right.
Whereas when you guys make a mistake, it's like a big deal.
Hopefully not a fatal mistake, but mistakes always happen. And
well, you said the number one reason why people die is because of
medical errors. Yep.
Yeah.
Correct.
So I mean,
correct.
It happens,
and that could be like, there was a surgical complication from a heart surgery, and the patient died of an infection. That might be categorized under that, or the patient had a urinary catheter for some reason, and it got infected. They died. It could be something like that. Not necessarily like, the doctor literally should have done something different. It's a little more complex than that, but that's generally what they say.
Okay. So you said, and we were talking about work-life balance before, but the context then was residency.
Right.
You don't have any work-life balance when you're in your residency for the vast majority of programs.
Yeah.
Right?
Yeah. Sure.
And like, if the podcast right now is for somebody that's trying to become a doctor, we can't lie to you, right? I mean, at the end of the day, you're going to work a hell of a lot in those residency years, right? And so after that, do you feel like you have work-life balance? Now it seems like you do. 8:30 to 4:30. Are you out of the office by 4:30?
Usually five or so.
So that's like 8.5 hours. That's
my commute's not too bad. It's about 20 minutes.
It's really standard.
Yeah.
So that's pretty good. I mean, that gives you quite a bit of balance.
For like hospitalists, oftentimes it's 12-hour shifts.
Okay.
So 7 a.m., 7 p.m. They're on for a week for 7 days, and then they're off for a week. They're working 26 weeks a year. They get paid $350. Yeah.
What?
Yeah. Yeah.
That's pretty
So
awesome.
that's, and maybe
So
even more.
so
I
the
have a friend who makes in Las Vegas, he makes 500.
now I see why people do it,
Yeah.
right?
Now, would I want to do that? No, I'd be miserable. He saw 75 patients in a day once. I mean, forget
Oh
it.
my goodness.
Forget it,
Yeah.
But you make money.
Yeah.
So
And you save 75
so you
lives.
have a lot of
Well,
options,
hopefully
right?
they're
You can
not all
make
dying.
outpatient, inpatient, you can do out and inpatient, you can do part-time, you can do 1 week on, 1 week off, and do a side gig. You can do something else, right? So you can make even more money. You can do education, you can do academics, you can do research. You don't have to be a doctor and see patients. You can do administration. You can be a politician. There's just a lot of things you can do. You don't have to, but you still will have the DO or the MD, and you'll still be highly regarded and have options and have those accolades.
Okay, that's cool. So I didn't know that. So if you work at a hospital, it's only the minions, the residents, that are working psychotic hours. A regular doctor there is working 12-hour shifts.
Right.
And I'm guessing it's not as rigid as 7 day on, 7 day off. I'm guessing some of them have a malleable,
It could be,
schedule,
yeah. But
right?
typical hospitalists that's often how it works, is my understanding. Yeah.
Oh, okay. That's pretty cool. So you told me a lot about what you like about being a doctor. What do you not like about being a doctor outside of taking notes?
Um, Man, this is, I'm not the right guest for this because, I guess I'm not a usual physician in that I love what I do. So
No,
what do
no,
I
no.
not
There's
like about
lots of
being a
doctors that
doctor?
love what they do.
No, I know, but
Yeah.
I'm literally trying to think right now. I'm literally trying to think, and it's not that there aren't things that we don't like. I would say,
My best friend, when he wanted, when he was, so I didn't know him in high school. I met him in university, first day of university. And, but I am also best friends with his best friend. And he tells me that when they started high school in grade 9, this guy literally said to him on day 1, he's all like, I can't wait to be a doctor. And he was just like sitting in bio class, like just like infatuated with
yeah.
what he's about to take in. And so I met passionate doctors, and he's got to be the most passionate doctor I know.
Outside of patient care, which is like everything you do and very difficult and challenging and stimulating, you have to do what's called continuing medical education, which is like, and it's good, right? The intention's good. It's like learning about certain medical conditions, and the field's always changing, right? New medications coming out, new research, new trials, data is changing. It's an ever evolving field, but you might have to pay for certain things, go to a conference, which, it's just perks. You get free food, everything like that. But it takes time out of your schedule. You might have to pay extra money. You get continuous medical education funds from my group. They give that's part of the contract. Your hospital, they'll pay for that, right? But it's just an added task you have to do. It's like, I'm doing continuous medical education day in and day out. I have to do more of it. It's kind of the checklists never really end, right? So that's kind of a hassle.
That's interesting. Continuous legal education is pretty, I feel like it's annoying in the beginning. Sorry, it's annoying after you have a little bit of experience. In the beginning, I found that it really helped, because when I first, or maybe that's just me, I have no idea how other people feel about this, but at least from my perspective, when I first entered the field, I didn't have global oversight over our problems. So whenever you're inexperienced, you only see like a localized issue, right? And it's not until you see a problem with so I'm a contracts attorney. Like, you have to see problems in every single provision like 50 times, and then you're like, oh, now I understand how everything works, why this provision interacts with this provision, right? Because everyone can read, we all speak English, right? I mean, if you live in the United States and you've undergone schooling here, you probably speak English. But so I found that in the beginning, continuous legal education was quite helpful because they explain things in such a broad oversight, like a broad perspective. And then, so it gives you a different view because you're just stuck in the nitty gritty, right? When you're working all the time. So I felt like it helped, but as time progresses, I feel like becomes a little bit of a pain. And I don't know how CME is, but CLE is like that. You have to sit in these like 12, 14-hour conferences
Right.
sometimes, but you can also do the 2-hour ones now. Now they have them online as well ever since COVID started.
Right.
So for us, at least we can do that. I don't know.
Yeah.
Can doctors do that?
Yeah, so it's very flexible. You can do online courses, you can do online lectures, you can do in person. There's no specific set programs you have to do.
Oh, okay.
But it's kind of like I'm working my butt off. Now I have to do more things.
I get it. I don't think
it's
anyone likes continuous
yeah,
education, to be
and the
honest.
money too. It costs money.
Yeah. So now that you're a full-fledged DO, you've been working for a bit, what kind of advice would you give to yourself back when you were in, when you were you're still in your undergrad and trying to be a doctor? Like, what advice would you give to young non-doctor Evan Gray?
I would say don't be so serious and take it easy and enjoy yourself when you can, right? I mean, we all have to, I had to do all the courses and study, but I think I was a little bit too much gung ho. I felt like I limited myself. I feel like I could have been a little bit more social more often. I feel like I kind of closed myself off a lot more than I should. And that's very common, of course, because you're trying to do the best you can, but I could have been more flexible. So I feel like just enjoy your life when you're in undergrad. Enjoy the experiences. It's a very unique time.
Yeah.
Do new experiences, try new things you like, things you don't like, and you're gonna meet people you might know for the rest of your life. So just have a time when you work your butt off, but have a time when you can decompress.
Yeah. It's funny. That's great advice because I learned that you can do both. I was the opposite. I didn't take school that seriously.
Right.
And I somehow did okay. But you can study, get fabulous grades, and have a really, really good time, right?
And I hate those people. Yeah.
Well, the thing is, I literally think the distinction is when you're 17, 18, 19 years old, your organizational skills are mega trash, right? You have no idea
Right.
how to actually put your day together, become organized, say that I'm going to be disciplined with respect to ABC, right? And today we have social media at like another level.
Right.
So,
right.
I mean, that doesn't really help. But if you're even the slightest bit organized and you can put in a small amount of time, like small being 2 hours, towards studying whatever
Right.
classes you attended, I feel like you can get straight A's. Right.
Yeah.
Like, and don't get me wrong, like pre-exam time, you have to put in extra long hours and things of
Right.
that nature. But, and that was the difference between me in undergrad and law school. In law school, all our exams were 100%. Right. So I was like, we are not messing around. I went into complete army camp mode,
Right.
and I
Right.
studied like morning 6:30 a.m. straight to 9 o'clock every single night. And I did in UK the exams are you get a month and a half off prior to writing the exams. So because
Wow.
it's all closed book and they're all 100% exams. So
Multiple choice or like
no,
you have to write,
you have to write them out. You have to
Yeah.
memorize case law. You have
Whew.
to memorize statutes. You have to like so.
That's harder than med school.
No, I don't know about that. We're given like 6-7 weeks off, and so that was the difference. In law school, I had that those organizational skills, and whereas in undergrad, it was just trying to figure it out.
Yep.
And
Yep.
I wish if they had done that, you can do both. You can also have a great time and spend a lot of time and really work on those relationships that will last forever.
Right. Right.
And just kill school because school's not that hard. It's just a matter of like, how many hours did you put?
Right. Organization is huge. That's one thing I forgot to mention when you said attributes. Organization and being regimented. That's huge. Yeah.
Yeah. So I close all the podcasts off with the same exact 2 questions because everyone's has they've received advice at some point. So I would like the audience to get some as well. So what is the best career advice you have received?
Don't be afraid to fail. Failure is how we learn mistakes. If you never fail, you'll never know what you did wrong. Failure is to be human, and so that's what we do. So the quicker you fail, or as Thomas Edison would say, the quicker you find things that don't. The quicker way that you find ways which things don't work, the quicker you'll be able to learn from that. So don't be afraid to participate, jump in, and make mistakes.
It's true. And what is the worst career advice you have received?
Don't be a doctor. It's too hard. It's too long. It's too grueling. You don't really make much money. By the time you get there, all the loans, you're not really going to be making much money at the end of the day. And I said, well, I'm going to prove you wrong. And I was a doctor, and I'm a doctor now, and I'm never looking back.
And that's the worst career advice.
Probably, yeah. I mean, I would say as soon as I stopped caring so much about what other people thought about me or what other people said about me, I became much, much more liberated, because all that matters is what's deep in your heart, what you want to do, what your convictions are, right? And if you're going to pay mind to what other people say about you, their opinions, then you're not living the life you want to live.
Yeah. And if you make a decision based on what other people want, you have to live with it for the rest of your life.
Exactly. Yep.
That's a big, big problem.
Yep.
Well, it was a pleasure. I think we have a solid idea on how to become a doctor, DO, NMD. I'll probably have an MD at some point as well. And thank you very much for coming by. Appreciate you sharing your journey. It was awesome.
Thank you so much. Yeah. Best of luck to everyone out there.
Well, that's it for this episode of the My Career Shop podcast. Hope you enjoyed it and got the opportunity to learn about how to become a doctor and what to expect once you actually become one. And actually, what to expect during the entire long, lengthy journey. If you have not already, please hit the subscribe button, give this video a like, and let me know what professions you would like me to interview next. Until next time.